without much delay, we shall kickstart the sessions, and later on we'll move on to in detail about it. For the first session, it's going to be 3 talks, which would be moderated by the chairpersons, Dr. Shankarappa from Manipal North Side. I request to chair the session, sir, and Dr. Farooqullah Khan from the lead intensivist, Bhagwan Mahavir Jain Hospital, Bangalore, and Dr. Ajit Kumar. I request Dr. Justin sir to chair the session, lead intensivist from Manipal, Kanakpura Road. So kindly chair the session. Now I would like to call upon the first speaker for the day, who needs no introduction, the senior cardiac intensivist and the academic director and the chief editor of Journal of Acute Care, and is an academic director of Narayana Health in Bangalore, who's going to deliberate on the topic which is most recent advances in the intensive care, which is Renin a new lactate. Sir, I welcome you, sir.
Good afternoon, one and all, and thank you so much for having me today here. I am greatly indebted to the organizing committee for the invitation, and I take great pride to be a part of this program. With that, I have no disclosures. This is a topic which is entitled "Is Renin a new lactate?" So, as you all know, sepsis and septic shock is a global healthcare problem and leading cause of death in the intensive care units worldwide. Anywhere from 20 to 40% of all global deaths in the intensive care occur because of septic shock. Identification of circulating biomarkers of septic shock may constitute clinically relevant approach to individualize patients at risk for worse outcomes early in the course of the disease. This will facilitate early and precise intervention to improve the clinical course. Currently used septic shock biomarkers, including the lactate, are not specific and have variable impact on the prognosis and disease management. Coming to the subject proper, the renin-angiotensin-aldosterone system is the endocrine pathway which is essential for the regulation of blood pressure and fluid hemostasis. This system influences various target organs and tissues, especially the vasculature, the heart, the brain, the kidney, adrenals, and the immune system. The activation of this system is likely an early event in septic shock process, and recent data reveal that the elevated levels of renin is a better predictor of worse outcomes in septic shock than the lactate and other predictors of mortality. We'll just have a brief outline on the basic pathophysiology involved, and then see whether it really should be considered as a new marker of septic shock. If you look at this angiotensinogen, which is produced by the liver, that is the precursor of angiotensin 1, and this angiotensin is acted upon by renin, which is released by the juxtamedullary apparatus of the kidneys in response to decreased blood pressure, decreased levels of angiotensin 2, increased sympathetic tone, and increased succinate in the blood. And this angiotensin is converted to angiotensinogen is converted to angiotensin 1 by the action of renin, and this angiotensin is converted by angiotensin converting enzyme, which is plentifully present in the pulmonary endothelium, into angiotensin 2, which is a powerful vasoconstrictor causing increasing the mean arterial blood pressure, increasing tissue perfusion, stimulating the immune system, and stimulating the production of aldosterone and the powerful vasoconstrictor endothelin. It is also acted upon by ACE2, that is the angiotensin converting enzyme 2, which produces angiotensin heptapeptide, which is labeled as angiotensin 1,2, which acts on MAS receptors to have counter-regulatory effects as compared to the angiotensin 2, that is the decreased blood pressure, decreased inflammation, decreasing the oxidative stress, and increasing the nitric oxide. And if you look at the figure 2, you can see that in patients who have septic shock, there is a 1,000-fold change in the renin levels, starting from 0.065 picomoles to 70 picomoles, and the mean value of this median value is somewhere about 5.1 picomole, beyond which the septic shock is likely to have a fatal outcome. And if you look at the renin quartiles, again high levels of renin are associated with adverse outcome. Despite the fact that renin levels are increased in septic shock, as the renin levels increase, the proportionate rise in the angiotensin II does not take place. So there is some sort of insensitivity to the action of renin on the angiotensin, which is responsible for the release of angiotensin, converting angiotensinogen to angiotensin 1, which in turn is converted to angiotensin 2 by the effect of the angiotensin converting enzyme. So, but despite the fact that renin levels may be increased, the angiotensin 2 levels may not proportionately increase because of a sort of insensitivity of this angiotensinogen effect on the angiotensin. And as I already mentioned, there is a counter response to the release of angiotensinogen, and the potential mechanism that is contributing to the attenuated angiotensin II response in septic shock patients is mentioned here. There are two pathways for renin-angiotensin system in the critically ill patient, that is the classic and non-classic pathways. And not only the pulmonary endothelium is responsible for conversion of angiotensin 1 to 2, but various other organs also take part. It is realized now that this conversion of angiotensin 1 to 2 may occur in other areas of the body, as is shown here. This is the non-classical renin-angiotensinogen mechanism, where the angiotensin is converted to heptapeptide angiotensin labeled as 1,7 by the action of angiotensin converting enzyme 2. This has counter-regulatory effects as compared to angiotensin 2. So this is highlighted in this slide. Angiotensin 2 and angiotensin heptapeptide, if you compare the actions, they are somewhat contradictory, and it is the balance of the action of these two agents which is responsible for the ultimate manifestation in a given patient. There is vasoconstriction, catecholamine production, decreased renal blood flow, and CNS-driven BP control on the angiotensin 2 side of the equation, whereas you get vasodilatation, production of nitric oxide which causes vasodilatation, increased renal blood flow, natriuresis, diuresis, and increased pulmonary blood flow when the angiotensin heptapeptide acts. So these effects are contradictory, and it depends upon the disease state in which the patient is in to realize what are the beneficial effects of these two counter-regulatory substances which are released in sepsis. If you look at the evidence, this is the vitamin C thiamine hydrocortisone trial, which was the first trial which was published in 2021 in JAMA, and after subgroup analysis and post hoc analysis, it has been shown that the levels of renin which are high are associated with increased 30-day mortality. Increased levels of renin are associated with increased mortality and decreased survival rate. And the other evidence in the literature which has shown that which is shown that renin serves as a marker of tissue perfusion, and it outperforms lactate as predictor of ICU mortality, and this has been evidently shown in several other trials. And in this paper, it is clearly shown that in non-survivors, the renin levels are higher, and this outperforms the lactate levels. Lactate levels are shown in blue, whereas renin levels are shown in the red. And this is a conclusive evidence to show that renin levels outperform the lactate levels in predicting mortality in patients who suffer septic shock. And this study also demonstrates that plasma renin concentration is associated with adverse renal outcome, probably through shock severity and insufficient glomerular efferent arterial vasoconstriction. This study, published in Critical Care Medicine, proves that for each 1 unit increase in the slope of the renin, the odds of mortality increases tenfold, which again substantiates the fact that increased renin levels are associated with mortality. And if the renin levels are higher than 0.5, the mortality jumps up tenfolds. There is again another evidence which shows that renin is a marker of tissue perfusion, septic shock, and mortality in septic patients. Again, non-survivors had a higher level of renin in this group subset of patients. Same thing is true in cardiac surgical patients. And based on this, you can say that because of the increased renin, the angiotensin II response may be subdued because of insensitivity of angiotensin I to convert itself into angiotensin II, and hence they have suggested that you can give exogenous angiotensin II in these patients to be able to provide the necessary vasoconstrictor effects which are necessary in these patients. In conclusion, the activation of renin angiotensin aldosterone system in septic shock is expected to is the expected response of this system to maintain blood pressure and adequate tissue perfusion. The counter regulatory hormones may functionally alter the response of the organism to the released angiotensinogen and angiotensin. And the rationale for therapeutic use of exogenous angiotensin II in septic shock is compelling, and this may be the future direction of treatment of these patients. Further investigation is clearly needed to identify biomarkers that most accurately reflect the health and function of renin angiotensin aldosterone system in septic shock, and those that may optimally guide the use of therapeutic angiotensin II to restore the renin angiotensin aldosterone system function. With that, I would like to thank the organizers for this excellent opportunity, and I would like to invite you for this workshop which is being held at Narayan Hrudayalaya next weekend. Please join us, and any submissions for Journal of Acute Care in the form of original articles, reviews, case reports are most welcome. Thank you so much.
We'll take the questions at the end of the session, sir. Thank you for the wonderful talk and enlightening us on the renin as a new lactate, sir. And now I call upon the next speaker, Dr. Ganesh KM, intensivist from Manipal Hospital, Bannerghatta Road, Bangalore, to speak on daily trauma. Welcome.
Good afternoon, all. At the outset, thank Manipal Yeshwantpur Hospital's team and Dr. Pradeep Rangappa sir for giving me this opportunity to deliberate here in the BICEP program regarding the daily trauma. So, as we all know, up to 7 to 10% of hospitalized patients have AKI, and the incidence goes up to 35% in the ICU patients. Associated with sepsis, the incidence goes up to 50%, and it is associated with increased mortality. So sepsis plus AKI is, has associated with increased mortality. And the best supportive care for these patients is renal replacement therapy or renal supportive therapy in the form of continuous renal replacement therapy or the intermittent renal replacement therapy. It depends on the choice of the intensivists, but majority of the time it is the CRRT which is recommended in these shock patients. And so that we get time for renal recovery. With this, any procedure done in the ICU is always associated with side effects, adverse side effects. And we should always take into consideration that first we should do no harm to the patients. So based on that, the daily trauma is the concept which was coined by Molinar. He's a Spanish nephrologist who came up with this concept called daily trauma, which basically covers all the aspects of the adverse effects associated with CRRT. And it is under-recognized, and that is why this this concept is coming up. So if you look into this, So this is the initiation phase. So there are complications in the CRRT cycle. So starting from the initiation phase, the maintenance phase, and the weaning phase. So all these complications put together constitutes the daily trauma or the CRRT trauma, which they commonly call. So coming to the vascular access issue, so this is at the initiation and at the weaning stage of the CRRT. So there could be complications when the insertion of the catheter, and there could be non-infectious complications as well. Non-infectious complications being stenosis of the vessels or thrombosis of the vessels, and pneumothorax when during the insertion of the catheter. So all this can be essentially, we can have a control over this by utilization of strict asepsis protocols while inserting the catheters, and use of ultrasound to prevent the inadvertent complications during insertion of the catheter. So because of the late non-infectious complications, that is the stenosis, the subclavian lines are usually avoided. The choice is usually the right jugular vein and the femoral. So coming to the maintenance phase, the complications associated during the maintenance phase. So it's all attributed to the loss of the vital substances which which transport across the semi-permeable membrane. So these vital and valuable substances, the loss is significant, and apart from the toxin removal, there are few physiological blood constituents also which is transported across the membranes, and higher the dose of CRRT, more the clearance of these physiological constituents. So which comprises of the electrolyte losses. To be specific, potassium loss is reported up to 5 to 25% in these patients undergoing CRRT, and the adequate recognition of that and treatment with the KCl supplementation can prevent hypokalemia associated morbidity and mortality. Hypophosphatemia is the most common side effect or adverse effect of CRRT. It's reported up to 65%, and it doesn't indicate that we have to change the antibiotic dosing, but we have to, when there is significant hypophosphatemia, it is better to look into the antibiotic dosing. And the presence of hypophosphatemia in patients undergoing CRRT is more to do with the quality indicator of the ICU. Hypomagnesemia is less reported. The incidence of less than 3%, and adequate supplementation with magnesium sulfate can be useful in these patients. Coming to the next part is the acid-base disorders. So the initiation of CRRT is usually for the metabolic acidosis or hyperkalemia or volume overload. So, but as a consequence of CRRT, there is overcorrection of sometimes the acidemia because of the buffers or removal of the acids, and it can lead to metabolic alkalosis. Apart from that, there is significant carbohydrate loss which has been reported up to 140 grams per day, and the maintenance of normoglycemia is the norm in all the ICU patients. Nitrogen loss is the other significant problem associated with CRRT, and supplementation with enteral protein, high protein diet up to 1.5 to 2 grams per kg body weight. And from the SPEN guidelines, they suggest that addition of amino acids, parenteral amino acids, as well as glutamine in these cohort of patients. The other significant loss which happens is the water-soluble vitamins and the trace elements. So they are all removed with the CRRT circuits, and supplementation with B12 supplementations or vitamin C supplementations along with thiamine is very much essential in these cohorts of patients. Though the trace element supplementation is not associated with increased survival, but it seems to be physiological to supplement these trace elements and vitamins. So apart from all the trace elements, important electrolytes, the drugs are also eliminated with the CRRT, and the most important one to consider is the antibiotic losses. It is because of the low protein binding, low volume of distribution and absorption on the CRRT circuit, the antibiotics are removed. And the guidelines are now available based on the PKPD principles of these antibiotics, and majority of the times the beta-lactams are to be given in the full dose, the loading as well as the maintenance dose, and there is no need to reduce the dose based on the creatinine clearance, especially in patients with CRRT. And there is this concept called CRRT paradox. Though the CRRT technique facilitates underdosing of the antibiotics, but we can safely give higher doses of these antibiotics with less toxicity in this patient. So that is the CRRT paradox. And the ideal way to have the dosing based on the TDM monitoring, but it is not available in all the places. One more important thing to note here is the T-half of the opioids and benzodiazepines are significantly increased, so accordingly the dose management has to be done for these drugs. The other complication is the heat loss. There is significant heat loss in CRRT when compared to the intermediate or renal replacement therapy. It is owing to that the majority of 24 hours a day the blood is circulated outside the body, so there is heat loss through that. And monitoring temperature and external warming can circumvent the complications of hypothermia, being increased oxygen demand, increased work of breathing. So heat loss is significantly associated with higher doses of CRRT, that is up to 45 mils per kg body weight dose. It's more commonly seen, and the negative effects as we already discussed. So the target is to maintain the body temperature above 37 degrees centigrade. The other problem is the clotting and the bleeding problems. So since the filter gets clotted, and heparin is the drug of choice for anticoagulation, but at the risk of HIT development or bleeding risks. But at the same time, we can use regional citrate anticoagulation, but it is also associated with citrate toxicity, and which is commonly seen as metabolic acidosis, hypernatremia, and hypocalcemia. The other important complication during any dialysis methodology is the intradialytic hypotension. It could be due to the reduced cardiac preload, impaired contractility, or the autonomic dysfunction which happens in these patients, which can lead on to significant intradialytic hypotension, and that is also associated with increased morbidity and mortality. Simultaneously, there is this concept of intradialytic hypertension also seen in these patients. It is again due to the sympathetic system overactivation, or the volume overload, or the renin, angiotensin, aldosterone system activation, or the endothelization. And even hypertension is also associated with increased morbidity and mortality. When coming to the hemodynamic monitoring per se, if the blood volume is more than 200 ml per minute, then the transformative thermodilution values are going to be falsely low. And the complications due to fluid management. So though the CRRT is initially initiated for hypervolemia, pulmonary edema, That can be initially tackled, but at the end of 72 hours, there will be cumulative fluid balance, positive fluid balance. That is also associated with poor outcomes, which we all know. So the other important thing here is when we are using the replacement fluid with high sodium, that is associated with fluid overload. So the same author came up with this checklist, which has to be looked into every day in the mornings and addressed all the issues. So all the issues here is addressed, and then the simultaneous actions to be considered also is given in this chart. So dilate trauma, or CRRT, is also known as CRRT trauma, is not only limited for the CRRT, but for any other dialysis methodology. The key here is early recognition and timely management of these complications. And hypophosphatemia doesn't mean that there is antibiotic underdosing, but it is imperative to look into the antibiotic dosing when there is significant hypophosphatemia. And the recommendation as per the authors to use the checklist every day. And we all know this, one dose doesn't fit all. So in the era of personalized medicine, it is imperative to look into the patient and tailor the needs for this patient based on the personalized targets.
And they plotted the mortality, and what they found is that in these 65 studies, the mortality was very, very different. None of them were similar to the other studies' mortality. But when they regrouped the same studies based on different blood pressures, or whether they have infection, or whether it was a suspected infection, it was a different story. There was a particular mortality attached to that particular subgroup. So maybe when we are looking at the sepsis or ARDS or any of these syndromes, probably we are looking at a lot of different things together, and probably that's why none of our clinical trials seem to give any sensible answer as such, and maybe we should divide them and make them more homogeneous groups, and that's where the phenotype comes in. It's basically making patients subgroups based on either biological, clinical, or physiological traits. And there are lots of different ways you can do subphenotypes. The commonest one, what I explained just now, is derived from clinical data. It can be done from imaging. It can be done from other physiological parameters. You can say that the inclusion criteria of a study is one phenotype, but we have understood that it is a very big phenotype, and probably we have to subdivide it further based on the re-evaluation of that study. But again, for a human, it is little difficult, I think, to go in so deep into those subphenotypes. But now with machine learning and AI, maybe those things will become easier as well. The other way the subphenotyping is done is looking at the proteins and inflammatory medias, and look at the mechanism underlying it and dividing the patients accordingly. The last one is the genomic expression data, based on the gene you subtype and see if patients behave differently. Example of the first one derived from the clinical data. This is probably the easiest one. You look at the clinical indicator and see if any meaningful groups can be made from that. Probably it is better compared to looking at the novel biomarkers, because they are very expensive and may not be available as such. And according to, this is one, there are lots of different studies, but this is one of the studies which was published in 2017. They retrospectively analyzed the data. They had about 64,000 patients, and they looked into demographic data, laboratory values, and pattern of organ dysfunction. And they were able to divide them into 4 novel sepsis phenotypes called alpha, beta, gamma, and delta. Alpha is probably more stable patient with fewer abnormal laboratory values and less organ dysfunction, whereas delta type is the one with the elevated serum lactate and hypertension. And when they divided like this, what they found is that the highest mortality, as you can expect, was in those group with in the delta type compared to alpha type, who were relatively healthier, and the mortality difference was 8 times higher, which you would think that you don't need phenotyping to know this. The sicker patients will do badly anyway. But there are other indicators like if you look at the proteins and inflammatory mediators, If you can subphenotype them into hypo and hyperinflammatory, that has been done with sepsis, ARDS, and COVID. I will show you one example of that. This is sort of a post hoc analysis of the FACT trial, where they looked into the ARDS group, and based on the levels of IL-6 and IL-8 and tumor necrosis factor receptor 1, which are pro-inflammatory, and some the higher level of that, and anti-inflammatory like protein C and bicarbonate, lower level of that, they group that as hyperinflammatory because they have higher inflammation. And those who didn't have that, they're grouped as hyperinflammatory. And when they divided this, actual FACT trial, the primary outcome was mortality, and there was no difference in mortality. But when they divided the same group into hyper and hypoosmolar, they found that hyperosmolar patients actually had a worse mortality. So probably we were looking at a different group altogether. Other one is gene expression data itself. Now this is VANISH study, where they looked into the circulating lymphocytes to identify sepsis phenotypes, and they divided them into SRS1 and SRS2. In SRS1, there was gene expression for T-cell exhaustion, deranged antigen presentation, and endotoxin tolerance, basically indicating that these are immunosuppressed group, compared to those SR2 who didn't have, who are immunocompetent group. And when they divided, again, VANISH trial looked at adrenaline and noradrenaline and vasopressin, and whether there was a mortality difference, and the study said that there was no mortality difference. But when they divided according to the genotype, they found that SRS1, who are immunosuppressed, had a higher mortality compared to SRS2. This is another way. So far what we have looked at is prognostication. You look at some phenotypes and you say that these patients will do well or not do well. There are other ways of looking at it as well, whether a particular treatment will work or will not work. And that's what I'll show next time. In the same VANISH trial, in the same group of authors looked at a different type. It was a 2x2 factorial trial, where apart from noradrenaline and vasopressin, they looked at whether hydrocortisone helps compared to a placebo as well. And what they found is that in SRS2 group, which was the immunocompetent group, if you give hydrocortisone, these patients do badly, because they are immunocompetent and you are given hydrocortisone, and mortality is increased compared to SRS1 group, where it is not that. And that is for immunomodulation. Even supportive therapy like giving fluid, this is a post hoc analysis of the FACT trial itself, where again there was no difference in 60-day mortality between the conservative and restricted group, but mechanical ventilation and ICU length of stay, there was a benefit in restrictive group. When they divided them into hyperinflammatory and hypoinflammatory group, when they looked at hyperinflammatory ARDS group, when a liberal fluid approach was given, they actually did better. The mortality was low. Whereas a hypoinflammatory group, if liberal fluid was given, they did badly. So probably there was no difference overall, because we didn't subdivide them into this group, and we just gave fluid to all of them, and probably they didn't do well. So, these are some of the uses, but there are a lot of other uses as well. With phenotyping, I think we are able to understand more about the disease pathology. And also, rather than categorically saying this patient will do bad and this patient will do, probably the disease is a continuous process, and maybe from less sick to more sick, how you treat them may differ as well, and how you quantify risk-benefit ratio for different treatment might differ as well. And it might give you avenues for new treatments. For example, we know that hyperinflammatory group has got IL-6 and IL-8 increased and others lower. Maybe you can have a targeted therapy where you can inhibit elements of inflammatory response with JAK or IL-6 inhibitors, or remove some of these pro-inflammatory mediators with cytokine absorption. And maybe you can have now so far, apart from giving fluids and giving vasopressors and giving antibiotic, we don't have anything else to do in sepsis. Whatever we have tried have not worked. But if you divide them into subphenotype, maybe you will have a better outcome. Having said that, right now, there is a lot of signal that it might be useful, but we are not there yet. we are still a long way away, and there are lots of barriers and challenges. The first one is most of this has come from the retrospective studies, retrospective post hoc analysis. This may be just a chance. We may be reading too much into something and trying to find association, and whether external validation is there, whether the reproducibility is there, it is difficult to say. Another thing is, most of these studies, because they are retrospective studies, they have used like hundreds and thousands of different biomarkers, and they have been able to show that there is a relationship how they respond. But in real life, that may not be possible. In real life, probably you need only a few markers which can be done very easily, maybe like a panel or something. Right now we don't have, but they are in the pipeline. Another thing is, you have to show that these phenotypes actually cause this outcome. For that, you need a randomized control trial. Right now, we do not have any randomized control trial. So right now, you cannot say that it is actually helpful. And last one, if really it is helpful, then we'll come to ethical dilemma. You know that in these patients it will work, in these patients it won't work. How do you say this patient that we are not going to treat you because it's not going to work? That will be the problem for the future. So what is the future direction? I think we need bedside detection tools which will make our life easy, and we need to integrate into our clinical workflow whenever it becomes a reality, and hopefully with the AI and integration of real world data, it will happen. And probably what we talk about personalized medicine may become a reality with phenotype, and we need clinical trials which are tailored to phenotypes. So right now what we are doing is we are looking at patients with sepsis, and we are doing studies, and we are seeing whether it's working or not. What will happen in future, people think, is that instead of that, you first look at the clinical traits and you see what phenotype they belong. And then you do studies individually on all these different, and probably then you get a better answer and better treatment options. And that is happening already. These are some of the 3 studies. One is called Panther trial, another one is called Traits platform, and another one is called Immunocept study. In Panther, they are looking at acute hypoxemic respiratory failure and looking at whether pharmacological therapies in hyper and hypoinflammatory groups, whether it will make any difference. And Trait is looking at treatable traits like lymphopenia with respiratory dysfunction or shock with inflammation. And Immunocept is looking at different immunomodulation stratified according to features like macrophage activation like syndrome or immunoparalysis and things like that. So some work is going on, but right now we have to wait. In conclusion, what I will say is phenotype is reshaping the landscape of critical care. It will help us to move towards precision medicine and improve outcomes. It is a step towards personalized and effective critical care. And for this, we need a collaborative research and innovation as a key for implementation. Thank you.
Thank you, sir, for the excellent talk. Now the house is open for the questions for 10 minutes. So on these first three sessions, if there are any questions, can be posed to the speakers.
Ganesh, you have to come here. Both questions together.
This is a question to Dr. Rajesh.
Thank you.
See, during COVID time, so we did all the inflammatory markers, IL-6 levels, then we used a lot of immunomodulators within short time.
Yeah.
Something like that, as you said, when the immunomodulators are very high, whether those patients can particularly target them with the steroid and fluids, more fluids as a, whether prospective studies can come up, whether we can do that.
Yes, I think it was actually during COVID time when these things in critical care medicine, in other specialty like asthma and breast cancers, they are already shown that phenotyping helps and it improves outcome. But in critical care medicine, we don't have. COVID was the time when the interest really increased. There were a lot of studies. I didn't include them because it is not relevant to us now. But looks like it is going to be helpful. But right now, we do not have any randomized control trials. And many of these, which right now it looks like you need about 1,000 different biomarkers and combined together to see a phenotype. It is not very practical. Maybe in future with AI and machine learning and all that, we will zero down to 3 or 4 biomarkers, which will give you a better idea. But right now we are not there.
Murli sir, about the Renin, so are we close to any diagnostics tool or tool or take long way to routinely available Renin practice?
I am told that it is available in India at a cost of about 5,000 rupees per test. But the The cost is one factor which will influence whether we are going to use it on a routine basis or not. And we need to more studies to prove that it is really the way to go forward. We need some
At this
time.
moment, is it superior to lactate or?
Yes, yes.
It's superior?
It looks to be superior to lactate.
Okay.
Will we be using it in all the patients in shock or only the selected patients who are not responding to?
The thing is, it has not yet come into the guidelines. So unless it comes in the guidelines, it will not be a common practice to be used. But if you have the facilities, you can always estimate and see what is the level and maybe give prognostic value based on the evidence available so far.
Some people say only use it in patients who are not responding to the regular hydrochrome and decide whether you can give angiotensin infusion.
That's true. That is true. That is absolutely true. You can certainly do if the facility is available. Why not?
Any other questions? Any inputs from the moderators? Sir?
Is the phenotyping using machine learning and AI, is anybody working on a app or a software where we can start?
Right now, a lot of studies are happening, and a lot of hospitals individually they are doing this. But I have not come across app. But app is only a matter of time. I think.
Yeah,
They
it can happen in
going
the
to be
background.
helpful. I'm sure apps will come.
Yeah, it can happen in the background, like
In the background. So many organizations are already, because they have so much data,
Okay.
they are reviewing, especially to identify patients early and things like that.
Yeah.
For phenotyping,
Biomarkers may not be, but
Yeah.
clinical phenotyping, like using the clinical
there is a
parameters.
lot of work going on.
Yeah.
Sorry.
I think as
I think more than app, it's probably the involvement of AI because I think what data we so far have is only dividing into its 4 categories, the alpha, beta, gamma. That's the only large study we have. But a lot of work is being done on gene mapping also. So I think that if all goes well, probably for a particular genetic makeup, putting together the comorbidities and then the predictability seems to be as high as 0.9. but to can process that degree of data, it might not be possible humanly.
Reading more into it, what I thought was probably genotyping is more important than phenotyping. I think with phenotyping we are reading more into it, and most of the time it just tells you that somebody is very sick, which is obvious to you anyway, and somebody who is very sick will not do well. So even though there is some signal that the hyperinflammatory, if you give fluid, it is good and things like that. But we may be reading too much actually. But probably genotyping is what in cancer and others, medicine as well. That's what has made a real difference rather than the phenotyping itself.
Does it make a difference in therapy? Like
Yes. Like in other branches of medicine, it is already showing. Most likely in critical care medicine also it will come. But right now we do not have that much.
so I think there is a lot of literature on neonatal sepsis, genotyping, a lot of data, and it is over a period of 15 years has not progressed because at the end of the day, genes as good as they are, it's a transcription factors and other omics which are more important, I believe, and hence the
That's what the phenotyping is.
It's not only genomics, so there's a combination of all the omics actually. That seems to show some early data of better prediction of how things can happen.
No.
Probably the ER level itself, if you have encrypted data of the DNA or whatever, then it looks like there can be a better prediction. That's what we talk about precision medicine.
Yeah.
It's not only about the 4 phenotypes as we know right now, but I think moving forward, it's a combination of this AI and deep learning, which is
Phenotype was only one study actually. They have
yeah,
looked at lots
that's
of
all.
different
That's all.
things.
So that's why it's probably going to be better in terms of prediction for the future. But yes, definitely it's a combination of few things because finally the phenotypic presentation is going to be determined by the genotypic makeup that way.
So obviously, to make things easier in a resource limited setting like currently how we are, like Pradeep keeps saying that an intensivist should be a good one to invest money because in stocks, because we are able to manage so many variables on a day-to-day basis when you stand at the end of the bed. Isn't Yeah, absolutely, absolutely true. So when you can analyze 26 variables, both clinical and biochemical otherwise, then you would think that we are doing a lot more human intelligence, which is currently a lot more intuitive, and do what we call as a Bayesian analysis of what we need to do for these patients. And I presume that's doing a good job already, and AI is struggling to match it, I believe, at this point of time. So hopefully it will do a better job.
But probably it will prove you wrong.
Hopefully. Obviously, at the end of the day, we'll always be happy to take the challenge, but yeah. Thanks.
We have to work together, I think, and it will benefit us. So thank you.
So as the theme goes for BICEP, what a brainstorming discussion it was. Thank you all the speakers. I would just request Dr. Manish sir and Dr. Manish Trivedi sir, Manish Rai sir to take over the seats. And I request Dr. Pradeep sir to hand over the token of appreciation to all the speakers. Dr. Rajesh Shetty sir. Play the music. Yeah. Yeah, it's okay, sir. It's okay. It's okay, sir. Thank you, sir. Thank you. Dr. Muralidhar Kanchi, sir.
इंस्टेंट मसाला चाय सिर्फ 10 सेकंड में बन जाए.
Dr. Ganesh. Dr. Shankarappa. Dr. Shankarappa, sir. Yes. That's Amen. Correct, madam, sir. Music stop, madam.
Full,
I,
can I, all the full formatting is changed. I get my
yes. Meanwhile, I'll call them. As we are all aware, today is the World Organ Donation Day. To commemorate the same thing, I would request Dr. Pradeep Rangappa to speak a few words and briefing and telling the importance of this day. Post that, we have the lamp lighting session and the things would go.
families come. Give me the connector. See, the whole formatting is changed here. I sort of anticipated that. It's okay, keep talking something.
Sorry for the technical glitch, it's just going to be a few seconds.
Yeah. Thank you, friends. Thanks for everyone who is assembled here. And thanks for all the audience who have logged in online. I think we have close to around 100 odd audience who have logged in pan-India. So today is a very special day, friends. I think this is a day that we all should remember as a team of intensivists and healthcare providers. And today is a World Organ Donation Day. So across the world, we are commemorating, and the theme for this World Organ Donation is answering the call. So what that really means, so answering the call is to pledge the organs. The call is to honor the families who have donated the organs, they've given the gift of life to save multiple lives, and the call is to collaborate with healthcare providers to heighten the program of organ donation to save more lives. I think this is the theme for this organ donation, and we need to reflect as to how we have been doing in the state of Karnataka, in India, and in Manipal, so that we all work together in a collaborative way and see how we can take this whole journey forward in a very meaningful way in saving multiple lives and with what we call as a gift of life. So just looking into the organ donation statistics, each one of us are involved in this. So India is in a very good situation. It's the third leading organ donation that is happening at this point of time. This is the graph from 2013 to 2023, and if you see, the graph seems to be steadily going up, and 2023 we had around 1037 deceased organ donors. And if you look into 2023, totally 18,378 donations have happened. If you want 2024 statistics, it's 18,900 transplants have happened, and it is third global leading. The first is China, first is USA, followed by China, and third is India. So India is well positioned with the number, but we are not enough, because India is a hugely populous country, and we have a long way to go. And the number of donations that have happened so far in India is 13,426 kidneys, liver is 4,491, and heart is around 221. But if you look the proportion, the number of CKDs in whole of India annually, this is per year, is 180,000 CKDs that tend to happen. So you can see the gap. So the number of deceased donor donations and the annual sort of a need for chronic kidney disease. And as I said, India is third globally, first is USA and second is China. And let's look into Karnataka. So Karnataka, we've had around 178 deceased organ donations, and that is second to Telangana. Telangana is the leading today, at this point of time, is the leading sort of a deceased organ donor program. But in Karnataka, from 2007 to 2024, there is 48-fold increase in the terms of deceased organ donors that are happening. And there are about 1,075 donors that have happened in Karnataka, and around 5,000 lives have been saved in Karnataka. So we are in a good state, which is working hard, and we are the second leading in whole of India. And if you look at the waiting list, in Karnataka, the kidneys, this 2024 data, 5,942 patients are waiting for kidneys from a deceased donor, 2,043 liver patients are waiting. These are all registered numbers, and heart, around 187 patients are waiting, and lungs around 79. So this is the data, registered data that we have in Karnataka who are awaiting for a deceased donor, so that their lives can be saved and they can restore their memories and they can look towards some sort of a hope. And most important, another important area where we need to focus on this World Organ Donation Day is the pledges. And if you look at the pledges in Karnataka, it is 75,000 organ donation pledges have happened from the community who are willing to donate after their death. And Bellary, if you want to look into the district, Bellary is the highest. So it's not about the learned Bangalore urban cities which are leading, it is our other districts which are actually leading the way, and Bellary, so it's a proud moment that other districts are taking the lead in this. And if you look at our MHY, Manipal Hospital Yeshwantpur organ donations, so 2022 to 24, we've had around 4 organ donations, and 2024 to 25, we had 5 organ donations. So totally we've had around 9 organ donations in Yeshwantpur. And in fact, it is a very humble sort of a moment here that we have a family of an organ donor who has come here. So we wish to really applaud them and salute them for the gift of life they have given to the patients, and they have given a new hope to the patients. So we are here with the hearts filled with gratitude and hearts filled with deep respect to this family, and who in the midst of lot of grief, they have thought beyond the grief, and they have gone ahead and given life to 5 patients, and they are leaving today through their sort of a vision that they have had. And the beautiful thing about this family is the patient himself was a doctor, he was a registered medical practitioner, and daughter who is here with us, Tulsi, she was a nurse. So this is the way people are looking at beyond as to how they can give a gift of life. So it is a sense of generosity, sense of benevolence is something that families are showing, and we are here to honor them, respect them with deep sense of humility and supplication. And these are the online pledges. So for all the doctors who may not be aware, there is an online portal by Nota where this is the latest number of pledges across India. So this is a pan-India sort of a dashboard. It will show state-wise, district-wise pledges that are happening in India, so that there is a movement from the government of India also to enhance these pledges so that we try to crank up the organ donations. And what is speciality about Bangalore? Bangalore, look at the transplant centers, highest transplant centers, 48, which means some of them not necessarily may be transplant, but these centers are authorized for organ retrievals as well. And Dakshin Kannada and Mysore stand second with regards to the highest number of transplant center. So our trends and initiatives have to be to promote, and these are the days we need to spread the noise, create a noise, and honor the families who have shown the pathway forward as to how we can sort of show the way and give the gift of life. So that is something we need to do. And establishing our sort of a progress is towards establishing non-transplant centers which should be authorized for retrieval of organs. And in 2023, SOTO is State Organ Tissue Transplant Organization. So Karnataka got the best emerging SOTO in 2023. So that's about it on this particular day. So again, at Manipal Hospital, so we bow our head and with deep sense of humility. So we wish to thank the family who are here. So we'll start this program by lighting the lamp. So I request the family to come forward, Tulsi and Lakshmipati's wife to come forward, along with our leadership of Manipal Hospital and all the faculty to please come forward for the lamp lighting, and then we'll take it from there. After lamp lighting, we'll felicitate the family, and there'll be address of audience by our leadership. Thank you. Thank you.
There's a short video clip on our journey of organ donation in MHY and also the organization. Now I request Dr. Manish Rai sir, Zonal Director of Millers Road and Northside and Manipal, Yeshwantpur and MHP to join for the lamp lighting, and Dr. Manish Trivedi sir, Cluster Director of Manipal Northside and Manipal Yeshwantpur, and Dr. Ranveer Singh, CMS of MHY, and Ms. Tulsi and Timmarajamma, the family of Lakshmi Pati, the proud organ donor, to join for the lamp lighting. And I request Dr. Pradeep Rangappa sir and Dr. Karthik sir to join.
Can I get all the faculty here?
Yes.
And Beena, our Chief of Nursing Services, to come forward. All the faculty for today. Raji can come forward.
I request the family to just be there for a few more minutes for the group photo. We honor you, and I request Ms. Tulsi to speak a few words.
ನಮಸ್ತೆ ಎವ್ರಿವನ್. ತುಂಬ ಖುಷಿ ಆಗ್ತಿದೆ. ನನ್ನ ತಂದೆ ಇವತ್ತು ಒಂದು 5 ಜನದ ಜೀವ ಉಳಿಸಿದ್ದಾರೆ ಅಂತ ಹೇಳೋಕ್ಕೆ ತುಂಬ ಹೆಮ್ಮೆ ಪಡ್ತೀನಿ. ಈ ಇನ್ಸಿಡೆಂಟ್ ಆದಮೇಲೆ ಡಿಸಿಷನ್ ತೊಗೊಳೋಕ್ಕೆ ತುಂಬ ಕಷ್ಟ ಆಯಿತು. ಬಟ್ ಒಂದು ಭೂಮಿಗೆ ಹೋದ್ಮೇಲೆ ದೇಹ ವೇಸ್ಟೆ. ಸೊ ಹಂಗಾಗಿ ನಮ್ಮ ತಂದೆಯಿಂದ 5 ಜನಕ್ಕೆ ಒಳ್ಳೆಯದಾಗುತ್ತೆ ಅಂದರೆ ಯಾಕೆ ನಾವು ಆರ್ಗನ್ ಡೊನೇಟ್ ಮಾಡಬಾರ್ದು ಅಂತ ಡಿಸೈಡ್ ಮಾಡಿದ್ದು. ಈಗ ನಾನು ಮೆಡಿಕಲ್ ಫೀಲ್ಡ್ ಇರೋದ್ರಿಂದ ಇನ್ನೊಬ್ರಿಗೆ ಹೆಲ್ಪ್ ಮಾಡಬೇಕು. ಇನ್ನೂ ನನ್ನ ತಂದೆ ಒಂದು 5 ಜನರ ಜೊತೆ ಇನ್ನೂ ಈ ಭೂಮಿ ಮೇಲೆ ಇರ್ತಾರೆ. ಯಾರೋ ತಂದೆಗೆ, ಯಾರೋ ತಾಯಿಗೆ, ಯಾರೋ ಬ್ರದರ್ಸ್ಗೆ, ಸಿಸ್ಟರ್ಸ್ಗೆ, ವೈಫ್ಗೆ, ಹಸ್ಬೆಂಡ್ಗೆ ಒಂದು ಜೀವ ಕೊಟ್ಟೋಗ್ತಾರೆ. ಅವರು ಅವ್ರ ಫ್ಯಾಮಿಲಿ ಜೊತೆ ಇನ್ನೊಂದು ಸ್ವಲ್ಪ ದಿನ ಹ್ಯಾಪಿಯಾಗಿ ಲೈಫ್ನ ಲೀಡ್ ಮಾಡ್ತಾರೆ ಅನ್ನೋ ಒಂದು ಥಾಟಲ್ಲಿ ನಾವು ಈ ಆರ್ಗನ್ ಡೊನೇಟ್ ಮಾಡಿದ್ದು. ನಾನು ಮೇಯ್ನು ನಮ್ಮ ಅಮ್ಮಂಗೆ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ತೀನಿ. ಅವರೇ ಫಸ್ಟ್ ಅದಕ್ಕೆ ಒಪ್ಕೊಂಡಿದ್ದು. ಹಂಗೆ ನನ್ನ ಫ್ಯಾಮಿಲಿ ಮೆಂಬರ್ಸ್ಗೆಲ್ರಿಗೂ ನಾನು ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ತೀನಿ. ಒಂದು ಸ್ಪೆಷಲ್ ಥ್ಯಾಂಕ್ಸ್ ಟು ICU ಡಾಕ್ಟರ್ಸ್, ಪ್ರತಿಭಾ ಮೇಡಮ್, ಕಾರ್ತಿಕ್ ಸರ್, ಅವರೆಲ್ಲ ತುಂಬ ಸಪೋರ್ಟಿಯಾಗಿ ನಿಂತ್ಕೊಂಡ್ರು. ಆ್ಯಂಡ್ ಕುಮಾರ್ ಸರ್, ಅಕ್ಷಯ ಮೇಡಮ್ಗೂ ತುಂಬ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ತೀನಿ. ಆ್ಯಂಡ್ ಮಣಿಪಾಲ್ ಹಾಸ್ಪಿಟಲ್ ಥ್ಯಾಂಕ್ಸ್ ಇವತ್ತು ಇನ್ವೈಟ್ ಮಾಡಿ ನನ್ನ ತಂದೆಗೆ ಒಂದು ಗೌರವ ಸಲ್ಲಿಸಿದ್ದಕ್ಕೆ ಎಲ್ರಿಗೂ ತುಂಬ ಹೃದಯದ ಧನ್ಯವಾದಗಳು. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Tulsi. I request Dr. Manish Rai sir to speak a few words.
Thank you, Ms. Tulsi, all the family members who have assembled today. And I think this is a supreme sacrifice from the family members. We can't thank you enough. And I think all of us should pay heed to what Ms. Tulsi told us. We are here for a limited duration. You, me, all of us in this room, we will exit this world one day, maybe planned, maybe unplanned. And it takes a lot of courage for the family members to agree to donate organs of a loved one. And if you ask me, and some of us in the audience, if we ask ourselves, this will be a very challenging time. And these decisions, they will not be made at the spur of the moment. And Dr. Pradeep was talking about the organ donation pledge that we can all enroll in. And I think apart from the organ organ donation enrollment pledge, it is also important to sensitize our family members. We have had situations in which the family members will overrule the decision of the deceased person. And I mean, maybe at times we realize that this is an emotionally surcharged environment, and we can't really think of reaching out, helping others when we ourselves are in so much pain, so much grief. I know that this is a topic that as regular human beings, all of us, we shy away from talking about death. All of us, we believe that illness, disease, death is for others. It is not for me. That is the paradox with which we run. And I'm also quite moved by the fact that we are number 3 in the world and number 2 in the country in terms of organ donations. So it tells me that we are on the right path. I would encourage all of us who are assembled in the room to really answer the call. And the call is to pledge our organs. We should be actively supporting this cause. And I don't see any reason why we are at a number 3. US with a population of 350 million. We have a population of 1.45 billion, 1,450 million. And our organ donation rate is at a 0.8 per 1,000 population, which is quite low. So there are cultural, religious barriers to us stepping forward and committing to organ donation. But I think it's a beautiful call. We realize, Ms. Tulsi stated that eventually all of us will go to waste, will go to dust. And if even at our dying moment, we realize that these organs, they can be put to use. There are 5 families, 8 families which will benefit from our supreme sacrifice. I think that is the rational call that we should take. And once again, thank you so much to the families who have assembled here. I truly salute you. It is always an immensely difficult decision. See, we can talk within the confines of a auditorium, but when it comes and eventually our time will also come. Maybe we are taking the decision or our loved ones are taking a decision. That is the acid test. And if we talk about it, if we prepare ourselves fully, I think we'll be able to take the right decision. Thank you so much.
Thank you, sir. We consider this as our privilege to honor the donor family. I request Dr. Manish Rai sir and Dr. Manish Trivedi, Dr. Ranveer, Dr. Pradeep Rangappa and Dr. Karthik Rao to join the felicitation of the family. I request Ms. Tulsi and Mrs. Timmarajamma to come onto the stage for a small felicitation. We honor you and we owe you. Oh, bravo. Okay. One more. Okay. We'll keep 2 chairs. So without much delay, we shall move on to our next sessions. We have an interesting pro-con debate coming up for the next. I would request Dr. Muralidhar Kanchi sir. He left, okay. Okay, Dr. Sunil Karan sir and Dr. Rajesh Shetty sir and Dr. Pradeep Rangappa sir to chair the session to moderate the pro-con debate. So now I would like to call upon Dr. Justine Gopal Das, lead intensivist at Manipal, Kanakpura Road, the most challenging topic, which is going to be very interesting, and we are looking forward for heated arguments and discussions. Intensivist-Led ICU Pro and Con. So Dr. Justin is going to speak on Pro.
Hello. Yeah. So, obviously, it's a forum of intensive care doctors, and I really don't have to make much of an effort to prove that you need an ICU lead for an ICU. As simple as it gets, I guess. Yeah. So, if you give, faster horses, they will only crash the cars, but they won't necessarily be the cars, I believe. Yeah. So I'm just taking the call about the ICU, where an intensivist leading and probably making a difference is what I think is what's going to happen. And in general, we always want to go through the simple task of telling ourselves what we do and why we are relevant is something that's more important for this conversation. So, being the first one to have a conversation, I'll have a little bit more general introduction about the why and what ICU is, and then obviously Chinna, as my close friend, can come up with the con about the whole thing. Isn't it? So, in current scenario where a healthcare which is supposed to be a team-based healthcare, ideally, and where a physician who shows competency in the said field, which is intensive care or critical care, and also shows dedication in terms of what we call as most of us have certain tasks for our jobs, and if we are diligent to it, then we call them the intensivists and I think. So, for all those who probably wanted to have a little bit more information about this, I would probably point to Pradeep's probably about a year-old video on ICU, which are led by intensivists, a talk about 20 minutes talk that he had given. And this was after this conversation about this study that has come through from South Korea, where there is a nationwide study of nearly 11 lakh people or more than 11 lakh people who are divided into sort of groups where people were essentially incentivized to work as intensive care doctors, and where it was not incentivized to work as an ICU doctors. And then they've overwhelmingly proved that the design where ICU is led by the intensivist, things have gone well. And this was not just like in a year or two ago, but this kind of conversation was going on for almost 25 years. I think from the time probably when the Manipal Old Airport Road started its own initial ICU, 94 to 96 onwards, this conversation about whether it should be led by a designated doctor or whether it be left to the conversations by various clinicians who may not necessarily have what we call as the ownership of the overall place. And so this is from 2002, 2014, and as recently as 2020, and even in the Indian study that was done by some of the people I'm sure you know on the list, that from a couple of Bangalore people in the group realized that in-house trained intensivists, even in places like India, and quite a lot of these centers are what we call the second-tier cities also. So it felt like the in-house intensivists probably would do better for the outcomes of these patients. So with that piece of information where I said that there is overwhelming medical data to prove, or literature shows that so-called intensivist-led ICUs would do better in terms of both the amount of time that the patient spends in the ICU, or the number of organ supports that they get in the quality of it, or the way that it survived through the ICU is probably a lot more cleaner. We'll leave that academic conversation out, and I thought I'll just brief you through what I think is an intensivist as we are. And we have a lot of models. We call it closed, open, or intensivist-led, or specialist-led, or high intensity, low intensity, multidisciplinary, or specialist units. So there are a lot of these words that come out whenever we talk about it, and each time we label it with a negative connotation, as if it's us versus them. And that's where the problem lies. So whenever you don't like something, you label it as something that's bad, rather than taking the good things out of the system rather than benefiting it. So this is where some of the units are labeled as open and more as a not so worthy, or some are closed as if mind is closed. It sounds easy to say, the mindset of the people inside are a closed mindset, which probably isn't. It's more collaborative than one may think. So these are all the models that come up, as a matter of fact, end up being said in a different way. So what I think is that we have ICUs, particularly in India, where there are low acute units, there are 25 bedded nursing homes where you are doing routine surgeries and you really need an ICU, even though you don't need an ICU because the law says so. And then that's a low acute unit where you really don't need an ICU patient unless something really went wrong, and at which time you just send them out somewhere. And to an extent where places like Yeshwanthpur, where we are, very high acuity center, where you have sick patients almost every day and every shift is being admitted to the ICU. So we always have to take with a pinch of salt when we say the literature grossly as one or the other. And so I want you to think about it in this terms. So the top left and the bottom right are the two corners where we feel like, which is where the discussion probably is, whether you want to have an intensivist-led conversation or not. We clearly know that low acuity, low intensity state, maybe you really don't need that because the demand is not enough to manage that. Whereas in high acuity and high intensity state, one would intuitively think, apart from knowing that the literature itself supports the data, that you would know that these are the things that are required. So when we come to the low acuity, high intensity, this is probably where one would think let's give us an example like in a CCU, where majority of the 90% of the patients are post-PTCS coming to sleep for 12 hours and going, and having a dedicated intensivist is something that they would think more like an impediment to the issue rather than a benefit to the overall outcome. And the amount of times that you would pick up a deteriorating patient is so low that it doesn't amount to the benefit. So again, that's another ground that one could cede, as one would say that. Whereas when it comes to high acuity, but when you want to provide low intensity care where the care isn't necessarily driven by an intensivist, that's where the money is. And understanding that is what I meant to say, is that the other way to, the laws of least effort, and what we call as the effort made by the organizations, a 25-bedded nursing home would rather like not to spend money on something that they don't necessarily use it. And whilst, a busier unit with a lot of admissions, they may want to spend at least a certain amount of money to staff the place. And so, at the end of the day, organization does this. Doctors do it as well. I think we take the least possible path. So at the end of the day, cost and benefit wise, rewards. I think we always look for rewards, and the easiest would want to take the least effort and most reward is what most of the people do. And unfortunately, intensivists are not that kind of a people, isn't it? Intensivists are not designed to do this. Yeah. So intensivists. Would I want audio? No. So intensivists are not necessarily the ones who are designed to do what we call as the take the norms of the least work and most pay. We exactly do the opposite in terms of do the most work and take the least pay. And you have to be a masochist to be like that. Yeah. So at the end of the day, so that's one of the ways why I wanted to say that why the mindset of an intensivist is different from intuitively others, and then that's probably one of the core principles of what makes a proactive intensive care is different. Yeah. In terms of ICU care, like we all think that ICU is about rush, isn't it? You know, they are like, you know, we are talking about the dialysis by, I think. So in a medical college, the nephrologist comes next day to see the patient in ICU, and then the resident says that patient had come, patient was breathless. I called the nephro registrar. He said he'll come after 30 minutes. He struggled with putting a line, and then finally patient died. So that happens all the time. It's what's called like in a poorly reactive state to a little bit more reactive state where you call the patients, like, you know, you make sure that somebody puts the line and waits for the like a nephrologist to write an order, and then you try to do it, and again there is a lot of time lost in this process. Whereas we come to another places where it is extremely reactive, where dialysis machine is already in the system. The minute patient gets called, patients are doing dialysis for the minute diagnosis is made, and so on and so forth. But we also want to know that rather than just being reactive, so which is what happens, isn't it? Like, a primary clinician may not want you to be as reactive as they like, you know, what you are going to do. You understand? Like, you know, I don't want you to dialyze the patient right away. And like, a clinician is, the ICU doctor is like, no, I really have to do it now. So these are the things where we call as there is what we call the excessive reaction is also counterproductive to the system, and that's essentially where we want reactive and proactive states. So we'll take another patient, the same CCU patient comes, cardiogenic shock, lactate of 14, pH of 7.1, 2 vasopressors, and like, you know, patient comes to the ICU. Like, you don't need a nephrologist, you put them on dialysis machine, CRRT, optimize the hemodynamics, because you get ahead, even though patient is making urine. That's because you want to clear the acid levels so that the vasopressor action is better, and then you benefit like this. And so that's called proactive thinking, where like you are not waiting for somebody to actually show a creatinine raise or kidneys not making urine and so on. So that's called proactive state. And so these come from what we call as expertise and experience and a certain amount of auditing. And so you have that adaptive mindset where you have to be able to not just tell yourself, but also the family, but also somebody else that you need a dialysis even though you are making urine. And that's where the difference is. So, and this is what we want, is that as the time goes by, a unit has to move from being reactive to proactive to predictive. And that step is only happens when you have somebody leading the system, I believe. I think I'll just take 30 seconds more. Another thing is that we always want to identify people, like, you know, we are in the business of looking after sicker patients, and then the earlier we attend to them, the better it is one would think it's quite intuitive. So like what we call as the beach flag scenario, most of the time between the two flags is when we get called, but the deterioration started much earlier. And this is what happens is that like, you know, as long as the numbers are between, they are deemed to be normal. And as I show here, in one of the patients recently, the patient started deterioration explicitly only in the last 4 hours. Whereas if I probably missed this. So his Muse score was getting worse over a day and a half. Everybody thought that, like, you know, the simple question would be like, why a 40-year-old post-op patient should need oxygen? Everybody thought that he's only on 1 or 2 liters of oxygen. So what we felt is that generally there are many roles for intensivist, which is direct clinical care, where he has to prove the expertise. It is about the management of the unit, it's the responsibility to the community, and showing the administration leadership causes. So overall, at the end of the day, what I meant to say is that the second most important aspect that we tend to do is the communication. Communication with between the department, between the departments and next of kin, and with the special circumstances involved in these places. And so overall, intensivist-led ICUs do the process versus outcome. We know that we do the right things for many people, and then outcomes will come automatically. And it's a proof is purely people in Bangalore. Many of us have gone through Manipal system, and particularly MHP, and then probably they would know that over the last 27 years, the outcomes have been kept because of the process work there. And so, yeah. So, with that, I'll close my side of the comments. Thank you.
We would like to welcome Dr. Chinnadurai. I think good friend. Unfortunately, we'll be talking con, but he's the Chief of Medical Services for the KIMS group of hospital, and very accomplished intensivist with special interest in organ donation and extracorporeal.
At the outset, good afternoon all. Thank you for the opportunity to be from the team. The topic given to me is because I'm not open ICU, semi-open ICU for almost 17 years. Nothing. So here also the topic is a little to be changed. It's not intensivist-led versus specialist-led. It is there also intensivist-led. There also it is intensivist-led. Whether it's purely intensivist-led or intensivist-led with other specialists. That's the talk. Because when I came to talk here, some of my friends joined with your team in Kanakpura Road. They all called me and said, Chinna, you have to talk and give back to Justin nicely. So with the lighter sense, I just want to. Because we know, I mean, Dr. Pradeep, me, Karthik joined together way back in 2008 in Columbia, Asia. Then I was in Hebal, Columbia, Asia alone. They came here. They were doing almost closed ICU here. Then I was doing a semi-closed ICU there. Okay, with that I just move on that. So the never-ending battle. The topics will be little changed. It's not closed versus this one. There is other model called completely closed versus hybrid ICUs. So you all know Florence Nightingale was the pioneer. She was the one in 18th century used this triage system and specialized care and saved thousands of lives. And later Peter, he also managed surgical separate, medical separate with the dedicated equipments monitoring, increased the definitely anesthetists took over from surgeons because surgeons didn't have much time to take care of the post-operative patients. So that they left to anesthesiologists to manage these patients. So anesthesiologists were managing ventilator care and circulatory, all that, so that outcome was better. As you know, that's 70s, all hospitals had ICUs. Initially, as you all know, only 5% of the total number of beds were ICU. Now, any major hospitals coming up with almost 25% of the beds or ICU beds, So when KIMS, we are opening almost 128 bedded ICU in one side, the other side is 108 bedded ICU. So it's almost 30% of our hospital beds are ICU because a lot of need there. So in 1970s, it's a optional consult. The patient can be admitted in ICU where, intensivists were called to see at least, optional. The primary physician can decide, but now it has become mandatory. So what I'm saying that here, intensivists will lead, but we accommodate other specialists also to the ICU to take care of the patients. That's what, it's not completely closed, it's a hybrid model. So, as you said, it's a closed ICU when all we know that clinically unstable patients, none of the consultant, other consultants want involved. It has multi-organ failure, it is your baby, you take care of, your team is take care of, please leave us. Namke was they want to, under there, care, because they know them, they know the patient, but sometimes the patients were with a follow-up for last 10 years. They don't want to suddenly lose those patients when it comes to critical care. They want a continuity of care, even critical. That's the many physicians request us actually. Otherwise, what happened? They come to the emergency room and worked on the patient for 1 hour. After that, go to ICU. That disconnect should not happen. That's the reason why, if the patient is clinically unstable with multiple organ failure, these patients generally admitted directly under critical care physician. So for in my ICU, I clearly tells, if nobody wants to admit under me. That is the instruction to the ER I'll give, because sometimes polytrauma patients say, hey, it's not my patient, it's not my patient, it's not my patients. The patient may end up in ER for 2 hours. I tell them, if nobody want to admit under us. All poisoning case by default admit under us. Hanging admitted under us actually. Any multi-organ failure admit under us. So that it's a collaborative where other intensivists also very happy, So the ER admission to here, this is what, normally happen. Can you alone can manage all this failure, right? I missed one, patients and relatives, the other biggest problem to manage. Being a critical care physician, in the daytime you have a lot of, maybe we have one doctor, whether one senior, 2 seniors or 2 juniors will be there. The evening time, the late night time, it's one intensivist will be led to manage, many of the patients, sicker patients. It may be always difficult. Evidence-based, most of the evidence, yes, it's giving closed ICU better outcome, but a lot of studies as a historical, and we cannot trust only, there is no prospective randomized trials were not there. Controversial, what is there is all historical data and limited RCT. This always in fight happens. It is my patients, your patients, my income is this month low, your income is this month low, so all that is happening, at the end, what happened, dissatisfaction is happening. See, being in administration, what I feel now, if any 15-bedded ICU at least need one team with a 2 consultant, 5 full-time registrars, 7 of them with a high pay, and eventually you may not be able to sustain for a long time. If they're 100-bedded ICU, we need 6 different clinical team. So if involve, other specialists all, we can reduce the cost to some extent. Evidence in favor of ICU, you shown the same article. In that article is Indian article, if you see still, most of the ICUs in India, it is open. In Bangalore, apart from I think Manipal and Fortis in Bannerghatta, all others are doing semi-closed ICU. Only, from, last 30 years, from Jose Chacko sir to Vineet Nair sir, I think they came down from Australia, they started in, early 2000 started. There what happened, it's maybe because of its all mature system where everyone have a fish to eat. Because every physician is in the OP and, they are busy on their own. They don't have to come to the ICU to fight with Sunil Karanti, it is my patient. Because everyone is, stuck in the OP, is so busy. Maybe that may be the reason. And you maybe are facing problems, a new hospital, physicians all under maybe tremendous stress to generate, department money. As I said, designation, consultant, less experience, outcomes are not bad. It is almost like 18%, most of the institute. Okay. So, critical care, we know all that, there should be critical care, lead consultant should be critical care, other consultants should, collaboratively discuss and leave it to the critical care physician to take a final decision. Definitely, these all studies all proven, yes, it is definitely mortality benefit is there when, it is led by critical care physicians. But, can we give these all studies, so anyway, I'll go, is only critical care physicians given all the, credit? It is not. What determines outcome of critical care unit? It is not only the critical care physician. It is like, we need a lot of protocol based. It's important. Whether you physicians are there or not, the system should run and, especially VAB bundle or, your venous thromboembolism prevention bundle, that should goes on, then only, your outcome will be fantastic. So we are not Superman. So over a period, we all realized, if anybody comes and tells, doctor, because of you, my father is alive, we say no, you know. We never think, young generation, they may think that way, but it's not true, you know. The lot of unpredictable factor decides your, your outcome, and lot of factors, protocols, your nursing staffing is very important. Your, in the nights, sometimes it happens, most of them will be junior nurses. Senior nurses all push the junior nurses to do the night shifts, which is, we have to balance such way. Even the nights also, there should be equal distribution between, senior most, intermediate and junior most nurses. The quality and continuous education is very important for proper outcome. This is a thoracic society, they also told, is there night intensivist staffing there is a really improved outcome? They say really no. There is a little controversial, like, for example, now, if your RRT team is good, you may pick the patients much earlier from your ward, where deterioration happening. If your RRT team is bad, as you said, mu score, 1.5 days, somebody missed it. This happens. Even in ICU, we see sometimes, nowadays we see even our nurses, some of the nurses forgot to even monitor simple temperature. Before it was thermometer, digital thermometer, and now they're using, before it was mercury, now digital. You press, double press, you go to reset, they keep writing 98.4. Some of them, my brain death patients' temperature went to less than 90. Less than 90. They already started having responsible and ethically responsible for that. So, goal of care is patient-centric and improved outcome. As I already, structure about hybrid ICU. Advantage around the clock, this is what happened. Protocolistic care, training staff, coordination, and communication with the patient caregivers and the family. Primary care physician can spend his time, energy in other clinical commitment. You can come and see the patient and say, okay, every doctors are taking care of very well, they will update you. You can go back to the team care and multidisciplinary approach, which rely on expertise in IC team. Admitting physicians, special expertise from other discipline is optimal strategy. The sustainable consumption of resource in ICU can be optimized. So overall, it is like collaborative management will give a good outcome. It is not his patient, it's not her patient, it is our patients. And for better outcome, I think collaborative care still stays strong. Thank you.
Yeah, thank you very much, Chinna. So I think points well made. So I call upon Justin for rebuttal for 2 minutes, and then Sunil and me would possibly have some comments, and then we'll close the session.
I think generally, I think Chinna took a softer position of semi, yeah. And then he has 2 people who are biased against you.
Yeah, correct.
As moderators.
No, 2 of them think we're sitting there, one closed, one semi-closed.
Okay.
Yeah, unclosed. You're also closed?
Yeah.
Oh, okay, right. Okay.
So at the end of the day, a lot of things what Chinna said is about the what we call as the money or resources in a broader sense. And so in a resource limited setting where the resources for like a lack of a word, whether they are unavailable even though they are available or actually not available, irrespective, then you have to come up with the jugaad, what we call it, jugaad. And at the end of the day, even under the state of jugaad, the essentially what the model that I did, you come up with the respiratory therapists and nurses. We came up with the 3 specialists around the clock, rather than and using some locums for the night, rather than having 5 specialists on the floor, and we disperse the money so that we capture the what we call the quality. And so we want to practice the ICU for the right reasons, not because the primary physician wants to go sit in the OPD, but just because we think it matters more. Number 2 is that as much as the primary physicians are good at managing the primary problems when the physiology is normal, when you are able to control your own body, versus when it is not so. That's quite a bigger difference. And that physiology assessment is part and parcel where I spent 2 decades learning as a skill. And I think I know that I'm going to be reasonably better at it and probably going to cause less harm to the patient. So that's the reason why I still believe that an intensivist-led, not necessarily closed or open or any other terminology in terms of intensity otherwise, is the one who is likely to be less intensive but more proactive or predictive to be able to provide what is considered to be the outcome for the patient and the unit, in a sense. I'll give you another example. In MHP in 16 to 19, for about 3.5 years, we did religiously changed 6 to 12 medications from IV to enteral, as in oral or NG, every single day during the rounds. And we showed that at the end of the year, for the next consecutive years, we had 6 deaths less. They were not thanking me, I was not taking credit for it, but we know that we made a difference there. So that only happens when you have an intensivist who is dedicated and responsible and shows commitment to the place where they work. Thank you.
Well, thank you, Justin. But see, India healthcare system is a little different than Western, where you all train Australia and a large extent. I'm saying that large extent. So now, are we ready for completely closed ICU in all the setup? That's a big question now. That big question.
Yeah. So I'll just make few comments. Yeah, you want to start?
Yeah.
Okay, Sunil.
So a couple of things. I think first of all, we have to understand that we are no less than Australia in today's terms. Fundamentally, it is important to understand that critical care, for anybody, us or the primary specialists, I think important to understand that it is a specialty. I think people accept that critical care is a specialty, these debates will happen. Now, if you ask 30 years ago, when I was doing MD, for example, a physician would put a badge as a cardiologist and work as a cardiologist, but today it's not accepted. So I think we are in evolution. Yes, we understand we are a relatively new specialty, maybe 3 decades old in terms of maturity. So that's the first point. One of the major concerns, I think, which come across for those people who are for or against intensivist is that, and we have had debates in a lot of our forums as well, where a non-intensivist has that, does people have the requisite qualification to run the program? I think that's one of the things which they always have concern. I think that has now changed in the country. We have different kinds of training programs, and I think that is where the difference lies. So today, I mean, maybe 20 years ago, what you said might have been true, but today I don't think that will be the thing. We are actually having, in next 4 years, I'm sure there'll be a demand-supply mismatch, and Dr. Manish might say, Sunil and Pradeep, you can find your way out of the hospital because I'll get cheaper people for a lesser cost, younger people. I mean, but that is one of the things. Now, irrespective of the cost, I think there was some talk that they can do something else, and that's true. Now, it's important to understand that, as I think you or someone mentioned, that critical care physiology is different, and I think we are also still learning about it every day. What we learned 20 years ago is not true today, and we were debating about precision medicine, genetics. I think if genetics and AI come into critical care, it's really going to fundamentally change the shape of critical care in the world, that's for sure. So there is a lot of emerging data to say that the genetics decides mortality. I think that was what, when that phenotypic time came, that was what I was trying to allude to. The genetics is going to merge into this, like how it has already merged with probably oncology and things like that. So if I am there to take care, and a good team is there to take care of the critical care patient of anybody, it could be whoever, I think it's important that the person has more time to spend on his other activities. It could be OT, it could be OPD, etc. Now, if you argue about producing more, generating more income, because you said in India that is the thing, I think that's an opportunity for the primary team to generate more income. Now, if you look at him coming into the ICU and putting a central line versus he's spending time in that central line 10 minutes looking after 2 patients and converting that into OT or admission, whatever, I think he will probably stand to earn more. And why break his head on something which is probably less rewarding for him and probably even for us, as he said, we are paid less and work more. If that is the scenario, why should he spend his time unnecessarily putting in this thing? But I agree to the point that when we say closed ICU, I think none of us believe that we are going to shut ourselves from the outside world. And that is not true even in Australia. I think when we talk about closed ICU, I'm sure Pradeep will agree that we will not accept a patient from a referral base unless it could be a base hospital or a level 2 hospital to a level 3, unless there is a primary ER mark. It could be neurology, neurology, it could be trauma, whatever. Of course, there are certain things comes directly to ICU, but unless the primary agrees, you can debate if I am wrong, unless the neurologist says I'm accepting the case, we will not take the patient into ICU as an inter-hospital transfer or whatever. So I think we are not saying we will not be taking opinions or things, but at the end of the day, I think the final say should be from the intensivist call. Yeah, some consensus, some debates. It's always good to have healthy debates. I think that is where it is. So I think these are a few things. And one of the other issues is how well your ICU is staffed. I think that makes a difference as well, because I know you said that night, I know the 2 studies which showed that there was no difference. But if you look at the study deeply, both those studies showed that the resource utilization was better with the nighttime intensivist. So I would still say that an intensive care led, covered, whatever you call it, ICU, and the ICU should be run by an intensivist, of course with all collaboration with other people. And it's also important to understand that we are a crossroads specialty. We will run across lots of specialties, and therefore literally, if I may extrapolate, we are literally the heart of the hospital, because today ICU is not only in the ICU, we are talking about quality. And if anybody talks about quality, I think the quality team first comes and reaches the ICU, because we deal with a lot of quality work. Whether we like it or not, we have to be part of that. And that is where I think our involvement or our implications beyond ICU is quite a bit.
Yeah.
That's what it was.
So I think everyone here are very clear that we need an intensivist-led. I think Chinna agrees. Justin, I think the argument is not that. I don't think any of us here present, we are custodians of intensive care. I am president-elect. So we need to see whether, when we say closed, what we mean. I think people are missing out on that definition of what. I think there were very valid and pertinent points Justin made. So what Justin is trying to say is we have to be proactive. When you say it is a not intensivist-led ICU, it becomes reactive. I think these 2 words are magical words. We need to pay attention. When we say proactive, decisions are executed and foreseeing a possible unfolding sentinel event, there are proactive changes for which we are not dependent on the specialty. Because now, very clearly, all of us are in the era of evidence-based medicine. If you have to stick to the evidence, I can go through 100 trials, all studies, even the nighttime intensivists. So when we are debating, we try to conceal the positive aspects. When they say nighttime intensivists, it means morning it was a closed ICU. Night times they had all the training. That's exactly what we'll sort of run here. So we need to be absolutely clear when we say intensivist-led ICU, the decisions are executed because evidence clearly points out more people are involved with a lot of their inputs which are acted upon. That is when you say it is semi-open. It has caused lot more harm and lot more deaths. And Korean study, we don't need any more. The countrywide study where Manishra is here, they incentivized doctors to run it as a closed ICU. And today, tell me one article in intensive care which shows 22% reduction in mortality and 12% reduction at the end of 1 year. There is no study in intensive care at this point of time. Just the fact they closed, and they showed across all specialties, ECMO, surgery, neurosurgery. So when we started intensive care, Chinna, we knew we had neurosurgery ICU, cardiac ICU, but today I think that model has to be admonished, because how can they run? They are not trained. Neurosurgeons are not trained. Liver surgeons are not trained. So they cannot run the ICU. They don't understand. We are there stationed there 365 days. Even our teams don't go to canteen. No specialty works the way we do. And we need a pound of whatever credit for what we do. And we don't want interferences which does harm to the patients. So here we are in the era, we had to look forward. So those were the models 25 years back. Even I trained from St. John's from 1998. We had a closed ICU. Radha is here. We had a closed ICU. Why? St. John's believes in closed ICU, and Australia produces the best outcomes. You look at SMRs worldwide, Australia is the best. Why? Because they run a closed units. So, but how we delineate what we close and collaborative ICU is a different story. But the decision, the final decision has to be an intensivist. It cannot be neurosurgeon telling you start an antibiotic. It cannot be a liver surgeon telling you give more fluids. It cannot be a general surgeon telling you don't feed him. These are rubbish, and this will kill the patient. We have done a study in our own surgical patients where surgeons were not feeding the patient. Sorry if any surgeons are here. We did a study and published it, and one of my trainees went to Australia based on that study. We showed by feeding early, it improves the outcome. So the clear message for each one of you, because there was a statement made in India by one of the intensivists saying India is going open ICU. I am here to say we have to champion a closed ICU, but how we define the closeness of the ICU in a collaborative way is what I think we need to take home. Take home is intensivist is the final say. In my charts, I don't want any others to write orders. They can suggest. I am open to all the suggestions, but the decisions is taken by me, by our intensive care team, because we are constantly engaging in training. Why are we called intensivists? Because we are intense, we are putting in so much of effort, energy into the best interest of our patients. And we need to have that sort of a space and ecosystem. And thanks to Manipal leadership and even Columbia Asia, I ran a closed ICU. I was not part of Manipal before. And how we did it, 1 year I ran the mortality. I came down from Australia, it was an open ICU. I ran mortality meets for 1 year and showed what are all the deficiencies other specialties are trying to do. And we closed it. And that is the way we have to move. So all friends of intensive care, I'm going to champion the closed model. And Chinna is running maybe a closed model, but it has to be intensivist-led ICU. Intensivist has to be making a decision. It's not a neurosurgeon in your ICU.
As you
it's
say,
not
they
a
come
surgeon
and
in
suggest.
ICU.
That's what you're getting.
I request Dr. Manish Rai sir also to join the debate, and he want
Closing comments.
No, debate, okay.
I just have to say he actually changed the question paper.
So, I'm not an intensivist. I'm a mere medical graduate. My comments are more outside in as an administrator. And I think for starters, this was not really a debate. There was no pro, there was no con. Both of them were talking about the same thing. And these ideological conceptions of closed ICU. Okay. So this whole notion of closed ICU, open ICU, in my eyes, it is a non-starter. Closed, it seems that the intensivists, they have a blockade and they'll not listen to anybody. And open is like, anybody comes inside and does whatever they want to do. It is primarily led by the initial admitting teams. And what I would think of is that in the evolution of ICUs, there is no debating that the ICUs, at least in the corporate hospital setups, are all intensivist-led ICUs. And my thought is that the intensivists, they have the final say. So please encourage your admitting teams to speak to you. It shouldn't be like President Trump, my way or the highway. You listen to them, but in any system, and I can tell you from an organization behavior perspective, that there has to be a final decision-making authority. And in my eyes, when patients, they have a deranged physiology, they have landed in the ICU, they can be neurosurgical patients, liver transplant patients, the primary responsibility vests with the intensivists. So you allow these teams to have their say, and if there is a dispute, maybe at times you will also agree to the next course of action. But maybe at times the suggestions coming your way are rubbish, like Dr. Pradeep alluded to. In that case, you should shoot down these suggestions and do what is in the best interest of the patient. And I think the disease burden is quite high. There is a huge middle class population which is exploding. We are seeing a growth in the healthcare domain. And I really don't think that you will have to fight for your pound of flesh. I don't think Dr. Sunil and Dr. Pradeep are going into the sunset in the coming future. They'll be very much here. And I don't think that intensivists are here because they are masochists or they decided during their medical graduation days that I will take up a very hard labor kind of a job with low pay. That is not a fact. I am privy to the payouts as well. But I would really think that as intensivists, you should put the patient health first, realize that ICUs is primarily the domain of the intensivists. Try collaborating with your peers, and if the need arises, take that final deciding call. That's about it. Thank you.
Thank you, sir. I now call upon Dr. Sandesh Kumar, intensivist from Cloud Physician, to deliberate on impact of AI in critical care.
Thank you, the earlier speakers, for setting the stage for me. From having a debate on, intensivist-led ICU versus non-intensivist-led ICU to technology-assisted intensivist-led ICU. So in the next 10 minutes or so, I'm gonna talk briefly about what technology tools are available. We hear a lot about artificial intelligence. AI is kind of the current buzzword today. So what that means for us in critical care. So that's a brief introduction. Thank you. Thank you, Pradeep sir, for giving this opportunity to share some viewpoints. So, I mean, we discussed enough about this. We all have had this call, you know, it's a 3 a.m. call, midnight. So we have a 58-year-old patient, had just had a, you know, Whipple's procedure, came to the unit late in the evening. You saw the patient and you have left, and then the resident calls you. Cannot pinpoint what's happening, but the nurse and the residents are worried that patient is not looking fine, right? And typically we know, you know, the confusion that happens on ground. You know, is this sepsis? Is the patient in pain? Was the patient, you know, not resuscitated enough? Is that the reason why patients have tachycardia? There are a lot of things that, you know, run down your mind. So, should I give more fluids? Should I escalate antibiotics? Should I start pressors? There are a lot of questions that are there, you know, and probably surgeons will come and hound you if you see the patient on pressors in the next day. So, there is a lot of data there. You know, there is a lot of data for you to interpret, and maybe not everybody is an expert right there on the floor to make that decision. Maybe an expert intensivist, just by the look of it, will be able to, you know, identify it, but not everybody is trained at that level to man the ICU 24/7. So you have time pressure, and whatever decision that you make impacts patients' morbidity and mortality. So we need clarity, and clarity doesn't exist in today's world. When you see ICU, the problem is not less data, the problem is more data. There is streams coming from, you know, the blood pressure, there is heart rate, there are a lot of lab reports that are coming in your way, and, you know, there are notes that got written, what happened in the OT. So there are lot of information available for you to interpret and then, you know, to come to a decision. So in the world of AI, that problem gets solved. So the AI will look at, the technology tool will look at all of this and alerts you and nudges you to make that decision, right? So that's what, you know, technology can do us, and there are already tools that are available to make it possible today. So what do we mean by, you know, technology, you know, AI? So we have heard, you know, as in the beginning I said, there are a lot of these tools, you know, we hear the buzzwords, artificial intelligence, machine learning, deep learning, and we know transformers, generative AI, so on and so forth. So let's keep all of that away, okay? So I would like to think technology or artificial intelligence as something which looks at, you know, tons of data, recognizes a pattern, and it helps in, you know, predicting something that is supposed to happen. If you had a human mind, probably it is going to take 6 hours late. A technology can do it faster. So just imagine that as a smart calculator, which is assessing the patient's risk, and it is something that never sleeps. You know, be at 3 a.m., be at 5 a.m., whatever time it is, it does the job accurately as it should, right? And the best tool actually is something that also tells you why did it. So for example, imagine that a tool that said, for example, at 3 a.m. it told you that this patient is at risk of sepsis, but it also tells you why the patient, it thinks that this patient has at risk of, sepsis. That's called as explainable AI, and most of the clinicians fear that, fear that autonomy going away. Why should I listen to some technology tool suggesting me something? So the technology is best when it suggests why it is telling, what it is saying. So it could be a rise in lactate, increase in respiratory rate, increase in heart rate, looking at all of those parameters and suggesting what it is suggesting. So, why are we discussing all of this now? So we know, as I said earlier, with more and more devices, more and more gadgets being available at bedside, it's not more, any simpler by just looking at one parameter to decide what the patient needs. So we have more data now, lot of information coming through arterial lines, central lines, maybe coming from your monitors. Humans are very, very good in understanding the context, but we do not have the same capacity or capability in recognizing a pattern. So that's what AI does well. The goal is to augment the teams that work on ground, and it's not to completely automate the care. Right? So where can AI help? There are 5 use cases that we clearly see. One is sepsis early warning systems, especially sepsis and clinical deterioration of patients with sepsis. Yeah, clear? So the second is, patients who are on ventilation and ARDS care, mortality prediction and complication prediction, helping in workflow, and all of us know ICU is one area which has lot of stress. So it can help with that. So it can also help you in predicting infections, helping you detect patients with AKI faster, and also targeted therapy guidance. Let's look at some of the tools that are available with respect to the early warning scoring system for sepsis and deterioration. So basically, it looks into a lot of data that is available in your electronic medical records. It could be the vital parameters, it could be the lab results, patient's urine output, and the notes that you write every single day. So it looks at all of this data and alerts hours before you can actually, a human brain can think and predict sepsis. So what it does is it reduces the time to initiation of antibiotics, and thereby, reducing the stay in ICU, and also to have some mortality benefits. So there are tools like the Deep ACE. So it is a deep learning algorithm which is developed by University of California and San Diego, which predicts risk of sepsis much earlier, enabling clinicians to initiate timely interventions. So we also have two FDA approved scoring systems, the Prognosis Sepsis Immunoscore and Algo DX score. So both of them also are clinical decision support systems that are available to predict sepsis early, thereby improving the overall care that you deliver. Recently we have this, just early beginning of this month, we had this, a study that got published. So we also have, this is kind of a, they looked at studies starting way back from 2012 to today. So they looked at about 6 studies, and in all of those 6 studies, about 3 studies predicted that most of them were clinically useful and be adoptable at bedside in helping predicting extubation failures. This looked at data coming from the ventilators, looked at the patient's images, looked at the notes that were available, looked at the vital parameters, and it can predict extubation failure rates. There are also studies which say that, for example, the phenotyping that we just discussed about, patients who respond well to PEEP, patients who do not respond well to PEEP. So phenotypical data can also be there. Now, with the genomics coming into picture, there is a lot of information that is available and you may not be able to interpret. So all of that is possible with the help of technology. And there are some early tools that are there. There are no FDA approved tools right now available to predict this, but some of these are implementable, of course, in a study pattern, and then we can look at it. And one of the things about all of these studies is most of these studies have poor external validity. So when they do a study, they have fed the data and worked in a certain model and certain population. It may not be easily representable to the population that is probably in India. So similarly, we have tools that can predict mortality. It is going to help you, in resource allocation. So let's say you have a patient and you know that this patient has very high risk of mortality. You can counsel the patient's family better. Or if there are enough additional risk factors and then you think that the treatment for the patient is futile, you can allocate resources judiciously based on that. You may not even admit the patient. Of course, it may be a different scenario in India where we do not generally refuse patients admission, but it may help in situations in a, let's say public funded hospitals where you need to carefully select which patient should the bed be allocated. Then you can make those decisions by looking at the data that you have at hand. So it will also help in, one of the biggest challenges that it can solve is the documentation. All of us clinicians are really, really bad at documenting. So probably some of these tools can really help. And this is something that is already being, the ambient listening tools are replacing the way you document. So you do not have to, just the conversation that you're having can go into a note. It can even place an order on your behalf based on the discussion that you had. And I spoke about this, in prediction of AKI, and it can also tell you what kind of fluids should you give, how much to give, and it can also help you when to start vasopressors, should I start early, should I start late? So all of those decisions can also be made with the help of technology. So we have enough studies. There are a lot of reviews that got published in 2024 and 2025 with fair amount of accuracy. The area under the receiver operative curve of about 90%, and there are some real world FDA tools which got cleared. So it looks like the future looks great. The evidence is also pointing towards greater adoption of technology in the near future. So of course there are risks. As I said earlier, it depends on the data that it learnt on, right? So it may not be easily replicable and it may not be easily applicable for everyone. We need to validate it locally. And it can also mean you may get too much alerts. Alert fatigue is a real thing because we know that even in monitors and ventilators, a lot of the times they just go and press the silent button. So it can still happen. And the black box, you need to know why not every tool that we have today explains why it is suggesting. So that's one of the biggest problem for adoption at bedside. And also any tool that you build need to fit into your workflow. If it isn't possible for you to fit into your workflow, the tool itself might fail. The tool itself may be excellent, but it did not fit into your workflow that you have at bedside, so it may not work. So of course there are ethics, governance, and data quality issues that all come because that's what it learns on. What I also want to say is, it is not a replacement to clinical judgment. Okay, so the AI is only going to suggest, AI is going to nudge you, and it is going to tell you what it is, but the clinician is the one who is going to finally decide. And one thing it cannot understand is it cannot understand emotions. It cannot know the complexities of how you work in an ICU, where the financial concerns are there. So all of that doesn't exist. And it doesn't see a patient's face, it doesn't know the family dynamics or what the values mean. It just interprets the data and tells you what needs to be done. And again, it is an advisor and it is not going to decide what needs to be done. And at the end, the clinician who is there at the bedside is the one who is going to decide that. So coming back to the patient that we discussed in the beginning, so 12 hours later, because it identified, you started antibiotics, you gave fluids and vasopressors, so patient is getting better. And it did not replace a clinician. It just nudged the clinician to take a better decision. So that's what I want to end the talk with.
Thank you, Dr. Sandesh. We'll take the questions at the end of the session. In the rush of handling this AI, which has no emotions, all the intensivists are exhausted, and I would call upon Dr. Amarja to speak on burnout among intensivists caring for oneself.
So good evening all. Thank you Manipal team for giving me the opportunity. After discussing about open or closed ICU, we are already convinced that closed ICU is better. And technology is probably going to help us in preventing burnout. So whether you have thought about burnout or you are only focusing on patient care, whether you have forgotten about caring yourself. So that's what I'm going to discuss. I have no conflicts of interest, and when I was preparing for this talk, I am also learning reasons for burnout, and I'm only focusing on how we can solve this issue. So my talk is focused on these aspects. What is burnout, how to identify, and what are the preventive strategies. If you look at this year's Doctor's Day theme, what it says, behind the mask, caring for caregivers. So who heals the healers? That is the theme for the year. And that itself tells us that we need to take care of ourselves. When I looked at a number of articles published about burnout, if you look at the year first article got published, it's 1981. It's not new problem. It was already existing long time back. And if you wonder what was the reason of burnout in 1981 and how it is different now, so that can help us in finding the solution to solve this issue. And last 10 years, probably there is rapid rise in articles published on this topic. Almost 80% literature is coming in last 10 years. Probably pandemic also has fueled this issue. If I look at the definition of burnout, it is defined in ICD-11, and it called as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And there are 3 dimensions to it. So what are these 3 dimensions? There is emotional concept, that is energy depletion and exhaustion. Second one is depersonalization. Though depersonalization is you are mechanically working in the ICU. You are just giving orders and you are not at all involved in patient care. And your attitude towards your colleagues, your patients is just a transaction. You are not involved in the patient care, so that is called as depersonalization. Cynicism is a word used which tells that it is an emotional detachment from your task, okay? And reduced professional efficacy. So ultimately it is leading to reduced professional efficacy, okay? And how we can measure the burnout? There are different scales for measuring the burnout. I'm not going to show you any articles. I'm going to focus on what are the strategies and how we can prevent it. The recent article which which came in the newspaper 3 days back, and what it tells, the incidence of burnout is 1 in 4 dogs are affected with burnout. Isn't it alarming figure? And we need to balance work-life, that is important. And see the first 2 lines of this article. The irritable resident doctor and the preoccupied consultant in a hospital could have one thing in common, and that is burnout, okay? So what it tells you, it could be because of personal, work-related or patient-related stress. This was a survey and it showed around 763 physicians which responded to it, and what they found, it was a personal, work-related and patient-related burnout. And what were the reasons? The reasons we have to look at carefully. These were inadequate recognition, substandard living conditions for doctors or trainees, unhealthy dietary practices. So we are only focusing on working atmosphere, but what about basic nutrition or dietary practices available for trainees, whether we have focused on that? What about insurance for doctors? If doctor is ill, getting admitted, how much your hospital is going to compensate or going to give medical benefit? Think about that. And incidents of violence from patients' relatives. So if you had experienced this issue, in future you will be little worried or reluctant that will be like depersonalization from your work, because your critical care profession demands that your complete involvement in patient care, and if you are emotionally affected, likely that your patient care is going to get affected. What are its implications? Implications are not limited to doctor alone. It is, by and large, it is affecting your patients and also the society. So this problem has to be solved. The risk factors this study showed, the younger age group, the age group less than 30, junior residents or faculties were more affected, probably less experience, and that caused more stress into them when they were dealing with patients who had complex altered physiology. Probably the knowledge they had was limited, and probably there was no support system which can help them to cope this situation. The gender, when I looked at the literature, majority it is suggesting that females are more affected and as compared to male. What about the marital status of the healthcare workers? So earlier studies had showed unmarried people were affected, but recent study has showed married, because the married people will have dual responsibility. They have to take care of the family as well as they have to take care of the work-related responsibilities. So probably this is one of the reasons. And last but not the least is how many hours you are working in your hospital. More than 12 hours? Think about your resident who has come for the duty in the evening and you are teaching him in the morning rounds, and just think about Is he capable of understanding what you are teaching? Because 12, 14 hours he is working and he is already drained out, burnout, and you are trying to teach him. Probably you have to think about all these aspects. And it's not just working hours. There are several aspects which are going to cause this issue. I'm going to discuss one by one. This article published in 1982, which told us there were 3 theories: stress theory, occupational theory, and role stress theory. So unless we understand these 3 theories, we are not going to solve this issue properly. What it tells, what are the symptoms? So think about your trainees is coming with constant fatigue or emotional stress, or he is taking repeated leaves, or he is having some emotional outbreaks. So think about what is happening. You are a leader of your ICU or administrator. You have to speak to him and find out what is the root cause of this problem and how I can help him as a team leader. Okay? And stress theory, what it tells, stress is nothing but a non-specific response of the body to any demand made upon it. In simple words, it is a expectation and outcome mismatch that leads to stress. Okay? And stress could be positive or negative. Can you tell me the example of positive stress? So probably you are preparing for exam and at the end you get the reward or award for this. So it probably a positive stress response. And what about if you are not getting recognition about your work, what it lead to? It will lead to burnout. So stress could be a positive or negative. How you take it is important. What about occupational stress theory? So this again tells you the magnitude of this problem. It is perceived as a threat to the individual's physiological and psychological equilibrium. I will give you 3 examples: job related, self or personality related, or there are some extrinsic stressors which can affect you. So work related. So probably these are the issues which can lead to stress, like salary, long working hours, no recognition, no support from your administrator to solve these issues. So that is the work-related stress. Okay? What about personality traits? So some people are going to fight the situation, some people are going to flight, or people are constantly anxious and they are not able to take any decisions. So think about what personality you belong and how you are going to come out of this issue. I will give you one example. What about commute time? Where do you stay and how far is your hospital? So this was one article which tells you that more the time taken to reach your hospital, the life satisfaction score is less. How many of you agree with this? Okay. So many people may think that it may not be true because how you take this as a stressor, because if you are utilizing this time, commute time, how you utilize? You probably are coming by public transport, you are interacting with people, and you are discussing apart from ICU patients. So you are utilizing time and probably are getting de-stressed. And that's what, the situation is same, but how you respond is most important. Role stress theory, there is an important role of administrator, role ambiguity. So you have appointed trainee and he is expert in one particular task or his knowledge is on particular task, and when he actually starts joining the duty, the amount of pressure put on him is too much and he is not able to take it. So that leads to role ambiguity. There is no clarity or about what role he has to perform, what are his expectations and what his superior expects. So when there is a mismatch, it leads to role ambiguity. It can worsen and it can lead to role conflict, and if both the situations exist, what it leads to? This person is going to work more and more without any recognition, and it leads to role overload. So we have to focus on these aspects. And compassion fatigue. So when you are treating critically ill patients, over a period of time, you are going to have compassion fatigue. And look at this sentence, what it tells you. You can't pour from an empty cup, and please take care of yourself. That is most important. I'm going to give you a few management strategies if I have time. So first and foremost is physician's well-being. So whose responsibility is this? Is it a responsibility of the doctor or your hospital? Probably not. See, at least institution can provide you different facilities like walking track, gym, or probably so think about it. You can demand for it because ultimately well-being of your team is more important, isn't it? But you can also take care of yourself by probably meditating, probably sports which you like. So there are ways you can overcome, and you can have some hobby, or you can do meditation, or involve in sports activity that can help you in de-stressing. What happens in hospital, if you are giving food to your trainees, what is accessible is not healthy. And if all the time you are telling your patients, please eat healthy food, but what you are eating, think about that. Okay? And the role of your organization per se, leadership role, work culture, how is your work culture? Are you open to discuss issues with your trainees? Whether your trainee is able to communicate real problems, how open you are to discuss these issues, or you are only interacting or discussing, or you are not aware when you are shifting from discussion to gossip. So be aware about it, okay? And you should have a culture of diversity, equity, and inclusion where you have equal opportunity for each of your trainees, and each one has its specific role, and it helps in building your team spirit. So think about this. Regulation of working hours. So how many shifts, how many working hours, what are your leave policies? When somebody asks you for leave, what is your response? Do you really easily give leave for your trainees, or you ask a lot of questions? And other scenario is the people in younger age want to earn more, they want more salary, so they work for long working hours, they do locum duties, and in that phase, what they develop, they can have some health issues, and they can easily shift into burnout. Look at this article. India is the most vacation deprived nation in the world. It was published in 2018. Whether what you are doing about yourself. So think about it. And if you suppose you have taken vacation, whether your boss calls you and tells you and gives some important task, or if on holiday you are seeing email and seeing WhatsApp messages, so are you utilizing your time? Probably not. So think about yourself when you have taken leave and all the gadgets are around, and probably you are not de-stressing yourself. Can this apply to healthcare? India needs right to disconnect. In healthcare, probably you can. I'm not sure. But even if you are on duty 9 to 5, after going home, you are still thinking about your patients. Probably you are attending calls and you are occupied most of the time, okay? So you need to take break from your schedule. Break means you are not talking about patients. So think about that. That is a real break. And there is a debate going on, how many hours we should work? 70 hours per week. Probably you can't apply this hypothesis in healthcare. Okay, when I'm showing you this image, what do you think? What it is showing? So how many of you recharge your mobile? All? All of you? What about yourself? So that's what, that it tells that for optimum functioning of device, you have to recharge. Same thing applies to human being. And self-care is not selfishness, okay? So you have to stay away from devices and reduce your screen time so that it can help you in spending time with your family members, and that is going to help you in balancing work and life. What about this? You can decide what task you are going to do. You can't have 10 tasks and you are having deadlines. Probably you are not going to complete and you are not giving justice to it. So focus on the things which matter. And I have given you two options. You decide which one you want.
It is integrating data, constantly it is integrating data. Right now, the newer hospitals, newer ICUs have already got embedded or incorporated, and there are ventilators coming where AI is incorporated, and there are monitors where AI is incorporated. So Muse, which you rightly said, is already in place, people are following it. So that's the future. So Sunil, any comments?
I thought Sandesh had left his chat board here.
So I think maybe not in our lifetime, not sure, but I think the future is going to be a smart ICU. The ICU will move to the bed rather than the patient moving into the ICU. Then I think this open-close debate also might not exist. But that's one thing. Just about the burnout, I think one of the things is, I mean, for people who like it or not, I don't know. I think it's important that you also love what you do. I think if that is something you love, so, you know, there are certain facets in your job you may not like doing it. So maybe don't get into that part. I'm not talking about fighting or arguing with people, but something, you know, like even the closed ICU, maybe you're happy to take care of patient, but you're not happy to maybe take part in administration. Though it comes as a part of your job in the ICU, maybe you can lessen your time with administration, you can do more of this thing. But some people might just enjoy the work of admin. So you can, so within the team, you can probably look at what people are happier to do. And as Dr. Pradeep mentioned, you know, build your own niche areas within the team. And that helps to actually not only improve the team dynamics and understanding, and you know, say for example, somebody is good at administration or good at family counseling or something, you know, just allow them to take care of that. I think she was talking about residents. You know, if somebody is very close to being to the trainees, they know, they understand the feel, pulse of the trainees, often the youngest consultant on the, in the group. So let them handle it so that, you know, you don't have to be involved with that and they will take care of these things. So I think that's where ladies do matter in the ICU. So anyway, yeah, thank you, that's all.
See, I do agree, Amarja, but the thing is, especially after post-graduation, when somebody has come for a specialized training, I do agree the leader has to take the role, but it is always the resident or the fellow who has to take it. They would have been mature enough, correct? So the self-care depends on self also. But every system will have certain thing. For example, when I started my FNB, I was 32 years old. I think everybody would have done it 25 years, correct? No, they will have the energy, but I cannot say I was a consultant in some other institute, now I have come for the fellow, so I cannot take the liberty. So what the system demands at the training period, that is very important, because personalization at that point of time, training is impossible. We have to fit into the system at that point. Over a period of time, when you become the consultant or you lead, you can always decide. But taking care of health, definitely I tell all my residents, including my medicine postgraduates, amma illirodilla. So nimman neevu nodkolbeku. Bengaluralli ella tarana option irutte, correcta? So breakfast miss madkondu ICU ಗೆ ಬರೋದಲ್ಲ ಅರ್ಥನೇ ಇಲ್ಲ. So that is in our hand. Whether we eat idli, whether we eat pasta, whether we eat muesli, that is left to me. But I should take care of that. That the organization or the leader, we can just ask, tindi tindra ashtane hortu, tindi tankodla, tarsla illa. But I still remember Dr. Vinit Nair sir used to get breakfast for everybody in the ICU.
To add to this point, I must say, Pradeep sir, even if he forgets to get his teeth, he carries a bag of fruits and snacks to us every day. From last year, 8 years we're seeing this.
Thank you. But taking care of self is in your hand. That much I can say.
Thank you. So I request Dr. Sunil sir to hand over the token of appreciation to Dr. Justin. Dr. Chinnadurai. Dr. Sandesh. Dr. Amarja. So we will move on to the next session. I would request the chairpersons, Dr. Justin and Dr. Rajesh Mohan Shetty and Dr. Radha to chair the sessions. Okay. I request Dr. Ajit sir to moderate the session, sir. Please. You also join. Dr. Radha, madam. Yes, sir. Please be seated. The next talk is on microbiome and ICU outcomes, emerging evidence by Dr. Pradeep.
Thanks everyone for being here. I think this mic working. Yeah. Thanks friends. So for all the nice discussions that we've had. So we have chosen little innovative topics which can pave path to the forefronts in intensive care. So this is one area I'm sure it was asked in DRNB exam, gut microbiome. So it's a new concept that is evolving, and it is terribly important that as intensivists we understand why gut has suddenly become important. So gut is like a microcosm. So if you look at the healthy gut, just you can focus, the green structure is the mucus. So all our gut has a nice mucus layer, and this nice rounded one are the goblet cells. And then you have all these sort of junctions, which are called tight junctions, which is holding the gut epithelium very closely, so that there's no translocation of bacteria. So there's a lot of bacteria, and all these are healthy bacteria, mainly anaerobes. So they're all floating around in the gut, and they are not meant to enter your circulation. So you have these tight junctions. So this is a typical healthy. So mucin, goblet cell. So then there is something very interesting that's happening in the healthy gut. So there is primary biliary acids, which get converted to the secondary biliary acids in the presence of anaerobic bacteria, along with short chain fatty acids. I think this is the new word in nutraceuticals that people are paying attention to. These short chain fatty acids are really important in protecting these goblet cells, because these goblet cells are needed to maintain the whole gut integrity, mucin production, so on and so forth, so that there is no translocation, because you don't want unhealthy bacteria entering into our bloodstream, because there is a blood vessel here. Once it enters, then they go into other sort of ramifications. So this is a critically ill. If someone becomes unwell, so they found this is what happens to the gut. As you see, the goblet cells have disappeared, the mucin has disappeared, and then the bacteria has gained entry into the lumen and into the blood vessels. So then there is the whole sort of a smoldering inflammatory cascade that tends to happen. There's some sort of a leukotrienes, interleukins, cytokines that get released, and then there is some storm, and there is a whole dissonance that tends to happen. So this is typically that happens when someone gets deconditioned and becoming more and more unwell. So what happens? This we call, this mechanism of transition from normal gut to that unhealthy gut is called dysbiosis. So that word is something intensive care trainees can remember. Dysbiosis happens when there is reduction in the beneficial anaerobes, and which again reiterating, mucus comes down. And these pathobionts is all the pathological bacteria which gains entry into the epithelial cells or across the epithelial cells, that we call it as pathobionts. So normal flora comes down, then there is an abnormal flora that tends to increase. So, and this increases. So when there is a pathobiont expansion, so there is a whole sort of an inflammatory cascade that gets activated. There is immune dysfunction. Of course, when there is immune dysfunction, cytokine, so the patients or any human will become vulnerable to increase in the nosocomial infections. So this is the typical sort of a cascade that we have understood, where gut dysbiosis happens when a healthy gut becomes unhealthy for whatever reason, and this pathobionts, which is all the abnormal bacteria, gains entry and creates havoc. So that's all is all about the understanding that we have. So when you look at the microbiome, it's a cosmic world within the gut. So the cosmic world in the gut has some functions. It produces short chain fatty acids. So if you Google today, the nutraceuticals is becoming bigger than pharmaceuticals, and there are a lot of products that claim that they're producing short chain fatty acids, prebiotics, probiotics, symbiotics. These are the buzz which are in the market, because this is with an intent that we protect the gut flora. And then this gut microbiome, which is a cosmos in itself, has an anti-inflammatory effect, and then it helps in wound healing, and then it leads to redox reduction. So this is all the beneficial effects of a normal gut that are there in normal human beings. So what happens when someone becomes sick and in ICU, someone is on a ventilator, so there is a sort of a reduction of all this normal gut flora. What are the commonest? There are zillions of normal gut flora. The commoner ones which are healthy gut flora are this Blauschia, Bifidobacterium, fecal bacterium, very simple to remember, Lactobacillus. We all have taken Lactobacillus. This is a normal gut flora. ruminococcus and subdoli granulum. So these are few of the salient ones which are present. They all get diminished when someone become unwell. But there are zillions of other normal gut flora which you can look up. Then there are these pathobionts, which are abnormal bacteria. They tend to gain entry and they increase in their strength or in their presence and they expand. So they are proteobacteria, staphylococcus. So that's a bad bug that should not be there in increased amount, and enterococcus and candida. So these are the ones which tends to overgo and replace the normal flora, and that is when the whole cascade of inflammatory response gets kicked in, cytokine storm, and all the problems happen. So now the question is, what are the risk factors for this gut microbiome to be disturbed? So any patients in ICU with whatever conditions they are in, but one remark I need to make is inappropriate antibiotic usage. I think this is something each one of us talk about it, but how well we are practicing, put your hands on your heart and tell how many times we are using inappropriate antibiotics. I think that is one singular factor which worsens the gut dysbiosis because it alters your normal microbiome in the gut. So if someone is on TPN, you are not feeding the patient, it leads to dysbiosis. Antibiotics. Studies have very clearly shown that if you give antibiotics more than 3 days, for whatever reason, gut dysbiosis happens and abnormal flora starts going. So antibiotics is the singular culprit that you can exercise caution in not using indiscriminately. And the presence of CVC lines or any other lines and gut dysmotility and epithelial dysfunctions due to whatever reasons, due to the stress ulcers, so on and so forth, and use of vasopressors, altered pH, and use of PPIs. That's why there is no role for routine use of PPIs in ICU because this alters the gut. So these are some of the typical situations where gut dysbiosis in ICU tends to happen. So for all the trainees, so this has led to something called axis because other organs get affected when the gut gets affected. They have called it as an axis. So the one axis is gut-lung axis. And they have done studies. These are all based out of certain physiological studies. So what happens is when there is an overgrowth of staphylococcus or enterococcus in the gut, so this becomes a trigger of someone developing ARDS. This has been shown, and they've identified certain chemicals. So there is des-aminotyrosine, which is normally present in the gut. If that gets impeded or interrupted, the defense against the influenza tends to get mitigated and they are more prone for severe influenza and ARDS. Then they have defined something called gut-brain axis. So where there is a lot of enterobacteriaceae in the gut, so these are the patients who are at a risk of developing delirium and increased ammonia producing sort of a gut organisms if they are present. So that can lead to brain edema and the organ dysfunction or encephalopathy that we call. So any ammonia producing organisms or enterobacteriaceae which are present or urease producing organisms, they all lead to brain dysfunctions which we call as gut-brain axis. Then there's something called gut-heart-kidney axis. So where they have shown when there is an inflammatory response that tends to happen in the gut, it can lead to myocardial dysfunction. And they've identified these two chemicals, trimethylamine and trimethylamine oxide. And there is reduced butyrase producing organisms like Clostridium, which can lead to myocardial dysfunctions and acute kidney injury when there is a gut dysbiosis that sets in, which we call it as gut-heart-kidney axis. So now the question is this important at all? So most of our ICU patients, if you look into this story I am narrating, they all would have dysbiosis. So what will dysbiosis lead to? So if you are using inappropriate antibiotics and if you have skewed up your gut microbiome, the studies have clearly shown it increases the mortality, increases the duration of mechanical ventilation, increases your ICU and hospital length of stay, increases the severity of illness, multi-organ and hospital acquired. So all the nosocomial infections tend to worsen if there is a gut dysbiosis that is happening in critically unwell patients. And we have some tools how we can mitigate this dysbiosis. So what are the treatment choices? I'm sure all of you know, studies have time and again shown early enteral nutrition. Don't fast the patients. So if you feed patients early, you are maintaining the mucosal integrity, you are maintaining the integrity of the mucin production, goblet cells, and give a balanced nutrition which is rich in short chain fatty acids, which will maintain the tight junctions and maintain the epithelial integrity. And most important, antimicrobial. So all these are doable, modifiable risk factors. So each one of us, I'm telling you, we are using indiscriminate antibiotics. With conviction, I'm telling each one of us sitting here. I don't think anyone is a saint here, including me, because that becomes a nature. And we have to exercise constant diligence and stop antibiotics, because studies have shown you give more than 3 days, that is when the dysbiosis, more than 3 days inappropriately, that's what I mean. Because if there is a very landmark article, if hemodynamically stable and you are giving antibiotic inappropriately, the study has very clearly shown it increases the mortality. Rather, where you have waited and exercised discretion in not giving antibiotics, it has saved lives. This multiple studies have shown. So these are simple things which we talk, but whether we are doing is something we all need to answer to ourselves. And antimicrobial stewardship has clearly shown not using indiscriminate antibiotics preserves the gut flora. So this is very important, friends, and this is where your closed ICU comes, because every specialist thinks he is an expert in using antibiotics. I have seen, even today if a specialist walks in, antibiotic on agbidona anta. What agbidona? Because this is what they are doing. They are causing gut dysbiosis and increasing the mortality. Everyone thinks they are an authority in antibiotics. And you take a liver surgeon or oncologist, they want to put all high-end antibiotics at the, on the day one. And you can start. Intensivists are meant to start antibiotics. I'm not telling, but stop it if it is not needed. Please stop it. For God's sake, stop it within 3 days. Don't continue more than 3 days, because studies have very clearly shown you continue longer, the worse is the dysbiosis that tends to happen. And probiotic, so this whole lot of debate, whole lot of science. So probiotics seem to be here to stay in some format. It tends to, I'll show you some of them, not too many studies, because this was just to give a teaser on the whole gut microbiome, has shown to prevent VAP. And this is an interesting concept, I'm sure few of you would be here, fecal microbiota transplant. These are extremes where you have failed miserably in feeding your patients early, you have failed miserably in following antimicrobial stewardship, you have failed miserably in feeding the right food, then you have to eat your feces. That's what the science is telling, because you have to eat the feces so that there is a passive immunity that you are gaining from another healthy feces of my other good friend. So this is what we are doing. So this is where science is evolving. And this has shown as a tool which can save patients in patients who have refractory Clostridium infections, because you have overgrown by allowing your gut to handle all the shit that others have done for you by giving antibiotics. So this is what we are doing. So what is fecal microbiota transplant has done? So it has advantages. They say it is useful for difficult to treat infections, very successful and increased effectiveness. So what it does is, basically you are taking a normal person's feces, because this feces has all the normal nice flora who is not taking antibiotics. So any good person who has not taken antibiotics has a nice feces, and you are taking the normal flora and trying to replace your abnormal flora in the gut because of the shit that you have done in your life. So this is what is happening. And the limitations of this is there are adverse effects, and decontamination is a problem because you're eating someone else's shit. And validity, whether that shit doesn't have other problems, is a problem, because the other shit also may have dirty bacteria, so we don't know the validity, and there are no large randomized controlled trials. So these are some of the oversight or insights on the fecal microbiota, and they're showing good sort of evidence, evolving evidence in saving lives by giving others feces in trying to protect gut and mitigating the dysbiosis. And interestingly, we'll talk a bit on probiotics, prebiotics, and synbiotics. So probiotics, all of us have taken lactobacillus, and all the good flora come in the pill form, which are dormant, you take them. So probiotics are all the fibers. So the short chain fatty acids, inulin, they're all commercially available. Synbiotics is a combination of probiotics and prebiotics. We call it as a synbiotics. Advantages is easy to consume. It is accessible rather than taking the fecal microbiota, and they have reduced side effect because these are all naturally derived, because these are all lactobacillus and fecal bacterium, so they are in the dormant form. And probiotic is all the, prebiotics is all the fibers. You take short chain fatty acid, isabgol, or there are so many other fibers that are available, inulin, so on and so forth. All that you can take it to improve your gut health. And now there is wellness clinics. If you go to any wellness clinics, they only give you this prebiotics, probiotics, synbiotics, so that you maintain your gut healthy and avoid getting into problem. And the limitations is the whole problem with prebiotics, probiotics. We do not know which prebiotics I need or which probiotics I need, and which is the sort of a good bowel flora that I am lacking. So whether we need to have specific formulation for different condition, and the validity of this clinical validity is questionable. And overuse of these probiotics, because you're taking a lot of gut flora or the gut bacteria, we don't know whether it increases the risk of hospital-acquired infections. And there are microbiota-derived treatment. We do not know the exact dose for using such things, and whether they, if in immunosuppressed, I'm sure most of you sitting here, you would know, in oncology patients who are taking immunosuppression, we don't give probiotics because their gut flora would be sort of deranged, and there would be some sort of a mucosal dysfunction, and there are immunologically challenged, so they are at a risk where these normal flora can translocate and lead to other infections. So it can lead to MODS, and we do not know how effective their role. Most of these roles are preventative. When someone becomes sick, you give prebiotics, probiotics, not necessarily. These are all preventative. You keep your gut very healthy even before the disease strikes you. Even before the cancer strikes you, keep your gut clean. It has a defense mechanism, not when the shit hits the roof, because that's when you may have to go for other modalities. So this is a most recent meta-analysis, 2024, published in ESPEN by Chinese. This is the largest meta-analysis which has shown a huge benefit with probiotics. So you take probiotics, it had favorable outcome in reducing mortality, reducing length of stay, reducing hospitalization, and all the good things that it showed. This was the largest reference randomized controlled trials. But as I said, they all have a role when someone is taking it and conditioning the gut prior to the disease. During the disease, they have shown, these studies are done in the critically unwell, but we do not know at this point of time whether we should use this as a standard of care. I am not very sure at this point of time. It's because ESPEN or ASPEN, American Society and European Society, they don't recommend prebiotics as a standard of care, but the evidence is evolving. So the take-home message, friend, is gut microbiome is a whole cosmos in itself. It's like a cosmic world within the gut. And they have a very beautiful mechanism in producing good. Short-chain fatty acids is good. We all need short-chain fatty acids. And they are needed for any wound healing. So gut microbiota has to be good. And for wound healing, you need a gut microbiota. For good immunity, we need a gut microbiota. And for all the redox potential, redox reduction, antioxidants, all that, you need a gut microbiota. And when someone becomes critically unwell, please remember your gut flora automatically tends to come down, and you have these other invasive organisms which sort of expand. And for all the trainees, remember there is a gut-lung axis, there is a gut-brain axis, and the gut-heart and kidney axis, which tends to affect these specific organs, specific to certain organisms' overgrowth within the gut. And the treatment choices are very simple. As you see, early nutrition, antimicrobial stewardship. Take-home lesson for you is please exercise 1000% of diligence. When you're starting antibiotics is not at all a big thing. Even a lay person can start, even a nurse can start. That is not the science. Science is when you can stop the antibiotics. Probiotics, keep reading, and I would suggest if your gut is unhealthy, so you can think of taking at least prebiotics, not probiotics. Probiotics is organisms, prebiotics at least fiber. So fiber is good. We all need good fiber. And symbiotics, I think we can take it prophylactically as a wellness. But in ICU, I'm not very sure. So if all this you are not able to do, so I'm sorry to say we all have to eat shit. So that's the last sort of a resort that we are left with. So thank you, friends. Thank you, one and all. So I request you all to submit valuable work. And of course, you can read to this lecture. Thank you. Okay, I think next speaker is Dr. Pratibha, who will be talking on ECMO and whether we are overdoing it, whether there are ethical outreach, and whether we are stepping out of our ethical boundary. Thank you.
Good evening, everyone. My topic is ECMO in 2025, expanding boundaries or ethical overreach. As an budding ECMO physician, I would definitely be a little biased and would be looking for, as an expanding boundaries, what are the possibilities and the fields where we can incorporate extracorporeal for the betterment of the patient. So as we know, the evolution of ECMO from the experimental to a mainstream therapy, it all started with, if you can see, this is Dr. John Gibbon and his wife Mary Gibbon, who worked on the first heart-lung machines in 1950s. From there, it started like William Koch, who worked on this wearable oxygenator. He was looking at how feasible it can be made and how smaller it can be accommodated. This is Dr. Robert Bartlett, the father of ECMO, who developed the possible oxygenator and who has saved this lives over the time. So as we all know, ECMO is a bridge. It's a bridge to therapy. It's not like, bridge, it's not the end point. It's going to be bridge to decision making, or bridge to therapy, or bridge to transplant, or bridge to some sort of endpoints. It's not going to be a treatment per se. So when we are talking about, we know the proper indications when we start on ECMO. When we consider the conventional indications, we should be looking at for the non-conventional indications as well. The expanding indications for ECMO are in like the sepsis. So this is the most challenging indication where we are like stuck with the the fine line between to choose the patient when in the early sepsis or in the late sepsis, because when we initiate the patient too early also, we may not be able to achieve the flows, and we might end up in losing the patient as well with whatever the parameters we're trying to match. We may not be able to match the demands. So this is the time where there is a uncoupling of heart rate or the heart compensation with the SVR and the heart elastance when the period between 48 to 72 hours, when we losing this uncoupling of the mechanism, that is when we have to be thinking of VA ECMO to consider the improvement of the flows and achieving the end organ, addressing the end organ parameters, like in decreasing the lactates or improving the perfusion rates. So the indications are like in SPP when less than 90 or MAP of less than 70 with VIP score of more than 50 at 1 hour or more than 45 at 8 hours with an urine output of less than 30, all that with lactates spiking up with a cardiac index of less than 1.8 to 2.1 liters per minute. So this is when you think of considering this. So there are various trials and studies which have been done. I'm not going in detail to it, which has showed benefit that improvement or initiation of an VA ECMO at a proper time, it would definitely help the patient in survival. We have seen that between like 60 to 71%, it has definitely helped in improving the end organ damage or preventing the further worsening and by improving the flows. So coming to the next indication where we consider in oncological patients. See, as the ELSO itself claims this as in oncology, it is a relative contraindication, someone who has an malignancy or immunosuppression. Again, it has to be chosen in the certain patients where we can help them. Like there are studies like the literature review has been done, and they have showed that like not all the malignant patients or not the patients who are already having a metastasis are there, like, if the platelet count, if the thrombocytopenia or if they have neutropenia or if they are a metastatic disease, they are upfront, they are not good candidates for the ECMO. It's going to be bridge to nowhere. So for solid tumors, in most of the reviews, they have clearly told that for solid tumors, the long-term survival was only from between 26 to 32%. Even if they survive this, the long term, they may not be really looking for a good outcome at that. And if you look at hematological stem cell transplantation, even at time, like beyond 146 days, if they survive, and if there is a need for if their pre-morbid condition, pre-morbid illness, if they were good, and the possibility of giving an ECMO, it can give a meaningful life to them, only then, or the reason for the indication going on an ECMO, if it is a reversible, then the consideration of ECMO would be a good thing. So in this meta-analysis and the review, they have clearly told that in the solid organ tumors, if the percentage, the total 72% patients, it was like almost 32% there was in mortality, and only 32% survived the discharge, whereas 61% died from ECMO. And patients who were included for solid organ, again, it was out of 14 patients, only 4 patients survived. And hematological malignancies who underwent ECMO, they had an upfront bad outcomes. So we need to be really careful whenever we are initiating someone with thrombocytopenia or neutropenia. Their morbidity is very high and mortality is very high. So when do we consider ECMO in oncological patients? It depends on the type and the stage of the patient. If the early or the primary malignancy is a curable one, or at an early stage, or it is just a bridge to some surgical repair, or you know that it's going to be a reversible one, then it can be considered. And the reason for ECMO, as I said, if it is for like elective conditions, sometimes there are many case reports stating that some patients presented for mediastinal excision, and then intraoperatively it was considered for ECMO because it was an inoperable complex situations. In that case, you know the primary disease can be operated. In that situations, it can be considered. And before considering all this, again, patient's age, performance status before the illness, and other comorbid illness has to be considered before making any decisions. And it can be considered as a bridge to chemotherapy, provided that it is a chemosensitive oncological disease. Otherwise, it's not really going to be beneficial. And then adjunctive perioperative support for solid tumors, again in surgical indications. So before considering any of the indications for an ECMO, it has to be a multidisciplinary ECMO, has to be made, and it has to be seen. Apart from these criteria which are met for VA and VV, we have to see for the other additional considerations in oncological patients. That is underlying primary disease, current critical illness which is going to be reversible or not, involvement of the other organs and other comorbids, and presence of any transplant associated complications, or if it is a multi-organ involvement, and also looking for and listening to the patient's will and the family expectations. All these have to be considered, and then post multidisciplinary team only the counseling, post that we have to consider the initiation of ECMO in such patients. The next indication where we can, non-conventional indication, is the eCPR. So as we all know, the ARDS trial, which was in 2019, and in the Inception trial, which was in 2023, which clearly said that eCPR was associated with significantly higher rates of ROS, better neurological outcomes, with substantial increase in the survival and the hospital discharge compared to the conventional CPRs. So there was another major Prague OHA study, which was done for an eCPR again, which showed there was no difference between the CPR or the conventional CPR or the eCPR, whereas a secondary analysis of the same thing which showed that eCPR based approach in a refractory OHCA was associated with increased organ donation, and the outcomes, like the out of 34 recipient patients, the 100% organ survival was observed after 1 year. So eCPR has to be considered. It is an evolving indication beyond the boundaries. And the next important thing, and also the evolutionary indication, I would say, as in organ preservation in death after circulatory death, that is donation after circulatory death, that is NRP, normothermic regional perfusion. So the normothermic regional perfusion, we can be considered in any circulatory death. After the circulatory death has been declared, there is a no-touch period, which is again depends on each country to country, which has been defined as in like 5 minutes to 20 minutes in different countries. Post that, you would be initiating an ECMO extracorporeal cannulation would be done, and you can see there are two types of NRPs, that is thoraco-abdominal and thoraco-abdominal NRP, and this is abdominal NRP. So thoraco-abdominal NRP is basically done with a cannulation into the right atrium and into the root of the aortic arch, and blocking the circulation to the brain by blocking the subclavian and the brachiocephalic, and only preserving for the heart and lung transplantation. Whereas for the abdominal NRP, you would be blocking the thoracic aorta by Fogarty's catheter, and it is used for procurement of the abdominal organs like kidney and liver. So this is going to be the mode of preservation in DCD patients. There are a lot of evidence evolving, and they have compared whether it was compared to the other routinely used organ preservation techniques like super rapid recovery. Super rapid recovery is, as soon as DCD is being announced, you would be taking the patient rapidly rushing into the OT and procuring the organs. Compared to that, NRP has definitely showed that there was the biliary complications were just 8% compared to 31% in SRR, and also ischemic related biliary lesions were just 2% versus 13% in SRR, and the graft loss also, it was just 12% versus 24% in SRR. So there are a lot of evidences from the systematic review trials and case publications which has clearly showed that NRP was associated with decreased delayed graft failure, and also with the ischemic failure of the biliary cells. And again, it is telling that NRP is going to be, and it would be made as an mode of organ preservation in all of the DCDs in coming in place. So the other non-conventional indications for ECMO use are like ECOR. There are various types of ECOR, which is AV core is, you can see it is the drainage in from the femoral, that is from the artery, and it goes to the vein. It's just it is used when there is a refractory hypercarbia, where without any, the arterial flow itself would function as a pump, and because of the flow differences, post-oxygenator and the sweep gas is connected here, it would be returned to the patient. And the other ECOR missions are Nova Lung and DCAP. In the DCAP, this works with the principle as in like CRRT, where the blood would be taken from the patient and it go through this oxygenator or the membrane lung. Post that, it would be connected to an ECMO filter in series, and it goes back to the patient. The other one is A-Lung. It is similar to the same Nova Lung, but it is a little expensive, which will not be not familiarly used. So other conditions are, indications are in thoracic surgeries, particularly if the complex tracheal resections or reconstructions are considered, or in high-risk cardiac interventions such as TAVR or any ventricular tachycardic ablations or complex PCIs you think of, any high-risk cases or hypothermic cardiac arrest or intractable seizures to prevent any hypoxic ischemic injuries. And we have spoken about advancements or the beyond the boundaries of indications of ECMO. We'd be looking at advancements in the ECMO technology. So when we talk about ECMO technology, this is the first trauma case which was put on ECMO. You can see the entire machine was occupying almost the room. So post from there to we are here to cardio help, which is just an handbag size, where you would be holding that machine for airlifting the patients or transferring the patients from one place to the other. So there are a lot of work going on in the miniaturization of the ECMO equipment. So this is one of the one which is Mobi box. This just looks like one handbag. The total console weighs here, this is around 2.5, and there is one more controller I would be showing. This is a controller which is a pneumatic device. So the advantage of this is it does not need any pumps. So whatever the weight associated with a routine ECMO machines are lost here. It's a pneumatic driven lines, and the oxygenation source is connected here. The machine would be operated with this small console like of a parameter. So this is going to be the way forward, where you would be just hand-holding a suitcase with a patient, and it can be airlifted in emergency situation, mobilization. It's not going to occupy any other space. So the other one is Breathe-Oxy 1 system, which is it must be if there are anyone who are with Marvel series. This is a robo, which is this machine, Breathe-Oxy 1 system machine was in lines with this robo. So it was made mainly for transport of the patient, especially in MRI or for any CTs or for even for the airlifting or any other situations, wherein it runs without battery for 3.5 hours. When you are connected to a battery, it's just that two things. One, you will have to be connected to a power source. It's as simple as an AC thing, and other one is it is an oxygenator one. So you will have an inbuilt oxygenator also along with it. With the oxygenator, even if you disconnect all the gas lines, it would work for 3.5 hours with the present oxygen present in the atmosphere, and it would give up to 5 liters of flow, and the sweep gas of around 10 liters, till 10 liters it can match. So the other one is pump lung unit system. This pump lung unit system, similar to the Breathe-Oxy 1, this is like it's going to be an handbag held of a sort, kind of this sort of a thing, where the console would have this inlet and outlet, and this was a 3D module which was virtually designed, and later on it was molded and it was designed, and it became a useful one, and it's an advanced thing now, and the people are working on it. So if this is an oxygenator and a sweep gas thing, this is a tray which can accomplish any moisture or anything, and this is a transparent opening where you can see this one and this, where you can see the both cannulas, whether the color changes are there or not, and all these sensors like the bubble detector and the oxygen sensor, everything is embodied in this small plate. So this will be carried on like a side hanging bag, and this is one more unit which is still under development, where along with this PL unit they are looking for one more RAPA, that is to support right ventricular thing also. This is motor unit where it can be used for a very long time, and the weight is around less than 30 lbs or something. And this is Maglev ECMO system BreathMo. This is one of the mission. It is yet to come. They are still working. The FDA is yet to approve this. It has the main feature or the main problem when we increase on the flows, there can be a lot of hemolysis because of the pump eating and all that. So with this mission, it comes within a magnetic flow where there is no pump attached to it. So because of this, no matter increase in the flows, it will not cause hemolysis, but it's still under development. It is being done only in animal studies yet. So we have spoken about AI in critical care. It is there everywhere. So AI in ECMO also is there. As we know, it is an ECMO PAL which using an ELSO registry is the largest registry maintained throughout the world for the patients who are put on ECMO. So including those patients, it has studied, and with the prediction, it gives a score, whether the prediction patients going on a VA ECMO, it gives a mortality rate of the patient. So till now, ECMO PAL is the first developed AI tool to guide us on the mortality and predict the survival of the patients. So AI is going to there in ECMO also by it is going to guide the clinicians based on whether the patient can be chosen for what sort of an ECMO or the risk stratification, and optimizing the ECMO parameters and treatment, and by entering the data as in the flows and the FiO2s and the sweep gas rates, it would be telling us when the patient is ready for weaning, when we consider decreasing on the flows and all that, and it enhances the clinical decision making. Even before any oxygenator gets blocked, it's going to give us a cue, like even for us to see for any oxygenator clots or anything, we would be looking at some P2, P3 differences or an invisible clot on the oxygenator, whereas this by including a lot of data over a period of times in such patients, it would give a cues even before there is a visible clot in the oxygenator. So again, there is one clinical thing which was an MRI, which is a portable MRI, because in ECMO patients we know that because of bleeding or because of ischemic injury, so there can be a lot of increase in the upfront. There is a 44% incidence of acute brain injury in ECMO patients. To mitigate, to transport such patients, though we are talking about miniaturization of the ECMO, there are still yet to come in the field. So transport such patients to MRI, it's going to be a difficult task. For us, to address this, so this safe MRI study was done in US on 52 patients. This is the ECMO, this is the MRI, portable MRI machine. You can see it just resembles an sonocyte machine which can be walked into the wards and can be used for patients who are on ECMO to detect an early brain injuries. And the images which were captured were absolutely matching to the, almost giving the similar images as into the conventional CT or the MRI. So what are we looking at future directions in ECMO? It is going to be an ambulatory ECMO, as I said. As the miniaturization of this ECMO is going to happen, it's just going to be one more suitcase or the sensor sitting next to the bed, and which can be given to the patient with LVADs or anything. Patients can be walking around with those units, and integration of the AI into the ECMO and bioartificial lungs and regenerative medicine that people are talking about when the patients are on ECMO, initiating on or considering the stem cell transformation into the lungs by helping in recovery of the ARDS lungs. It's also been under research. So coming to the ethical considerations, so there are a lot of things like, we have already knowing that ECMO is going to be a bridge to something, whether to a treatment decision or to a transplant. It should not be a decision to nowhere. Like, after we clearly know a sort of indications, like when you are initiating on someone who is already above 75 years, whose pre-morbid illness or the functional status was not really good, or having some metastatic disease sitting on the somewhere else, and know that it's just going to be just pulling on, it's not going to help him anywhere, we should not be considering in such situation, because resource optimization, as we know, ECMO is going to be a resource burden because it involves a lot of resources, like, from nursing to clinicians and people who are working for such patient. So it should be really given to the patients who are on need, not like when you're just initiate for someone because family asked, because someone asked, or because they want to live for long. It should not be done. It should be considered as bridge to definitive plan. And the other ethical consideration, whenever you initiate on eCPR, so the family, like initially when they come to an in-hospital, when they come to ER and they have when they have an arrest and we initiate on CPR, but then after 24 to 48, 24 hours, they may not be in a state to understand whether they wouldn't have been given a time for the neurological recovery. In such situations, how ethical are we to pull out this CPR, ECMO to withdrawal of the care? It is again a dilemma. It's going to be a large topic to discuss on. And again, when we are speaking about organ preservations in terms of NRP, whether to do an post-mortem cannulation or an ante-mortem cannulation. Again, in ante-mortem cannulation, how good or how feasible it is for someone to counsel the patients who are in ICU, in circulatory death, they're going to die, and even before any death has been declared, you're going to put some lines and keep just to tell them that we are going to procure organs. Again, it's going to be an ethical dilemma to ask on. And in oncological patients, as I already mentioned, whether there would be some patients who have already some med sitting somewhere, but then his functional status was good. But then we clearly know even after putting on ECMO, their endpoint may not be towards the treatment. In such cases, how ethical are we that we have exhausted resource on them and then looking for, we're not really saving the other patients who are in need. So I'm ending this talk. We should be considering the innovations or the considerations as an ability to change and the opportunity to grow, and not as a threat. Thank you.
Okay, so good evening, everyone. Slides. Yeah. I think I'll borrow a couple of lines from the last two slides which Dr. Pratibha showed. One is, of course, regenerative medicine, and of course the ethics of how ECMO thing. So I mean, I know there's a lot of talk we did about phenotypic, genotypic, so many things and so many advances which are kind of things that we have spoken about. It's very important to actually also parallelly understand end-of-life care, because at the end of the day, we should understand that we can't blame God. I think where to call off the line of what we would consider as good death, I think is extremely important. So gone are the days when you would say that we will be trying to save every other possible individual, and focusing the care from cure to what we would consider as comfort is something that we will be it's also an evolving science, of course. And the implications for this are much beyond only the medicine of it. I think there's a legal implication, there's an ethical implication, maybe a spiritual implication, a lot of things that we would need to address. A very important survey in the UK, which was a worldwide kind of a study, ranked India quite poorly. I mean, I know we are ranked poorly in quite a few things, but I think from then to now, in the last 1 decade, we have seen quite a bit of work done in this sphere of critical care, or sphere of what we would consider as part of medicine. Now, one of the major constraints for us has been the poor access to palliative care. I think there are two reasons for this. One is the fact that understanding the concept of palliative care has been a bit of a deficient state. Legal, of course, touching this sensitive topic is always going to be difficult for any political party or any politician. And more importantly, I think our own understanding of this as a society has also been a bit deprived, but I think we are getting there. So a few important definitions. I think firstly, what is futility? There's a lot of redefinition, and this is of course from the joint position statement from IAPC and ISCCM, which is nothing but it's a state where you would consider that the desired outcome in terms of both survival and quality of life, that is very important. It's not only how you live, but it's not only how long you live, but how you live also becomes a very, very important part of this decision-making process in terms of defining what is futility and whether you're able to achieve this goal from a perspective having a better, of a good long-term or a permanent outcome. Now, in terms of physiological futility, there are a lot of scoring systems and it's probably a little bit difficult to define, but this is in the broad definition. Now, definition can only be a definition. I think there's a lot of subjectivity in that, I do understand. The next is, of course, what is to understand what is called as terminal illness, and it's nothing but an incurable or an irreversible advanced disease condition. In the ICU context, I think it is quite easy to define an irreversible state, particularly in some specific objective settings like, brainstem death or somebody whom you would consider as a physiological irreversible state in terms of progressive multi-organ failure with the background of whatever. But this probably may become a little difficult in defining in a pre-ICU state, advanced malignancy or somebody who has an advanced neurological condition, etc. Then, of course, the definition of what is called as advanced medical directive, where you have a pre-written advanced declaration made by the patient himself in terms of helping the decision-making process and having a documentation done. Of course, here again, there is a bit of a gray zone where the Indian law says that the next of kin can turn it across or turn it around upside down to actually allow the person to go through the necessary rigors of ICU, if I may say. Two other important definitions: withholding of life-sustaining treatment and withdrawal of life-sustaining treatment. So I will not go into the detailed definition of it, but I think the difference, what you need to understand is withholding is not initiating, and withdrawal is, of course, interrupting the life-sustaining treatment. And there's a big definition, you can go and read up about it. Constraints of time, I will not get much into that. Now, what are the requirements for a good death? Of course, good communication, respecting the various norms of the patient, spiritual, cultural, religious, understanding the distress that the family is going through. Very important part to actually address that, because you can't force your way through, you can't road roll your way through. That is something you need to understand. Give the patient the autonomy of decision making. When I say patient, I may even surrogately mean the surrogate, okay? Can't keep repeating that statement, but when I say patient, I'm taking patient family as a single unit, particularly in the context of ICU. Preferring a place to die, as you know, 30 years ago, if you look at data, most deaths happen at home, but today most deaths do happen in the hospital, especially in the urban areas. And we don't want to prolong life unnecessarily, and understanding the deep significance of what all this means, that's very important. The family needs to understand, the patient needs to understand, only then they can take what is called as a informed decision about it. And of course, ensuring that there is no burden that the patient or the family will carry later on, including the important bottom line is the right to terminate one's life. I think that's what we are coming to at the end of the day. And when I say terminating of life, it's not based on a call because, I don't like somebody, or I failed in love, or whatever that you want, or I got less marks in 12th, not based on that, but based on the fact that my longevity is not going to give me a good quality or a good productive socioeconomic life. So 4 facets to UOL. One is, of course, establishment of futility of further management. I think that's the foundation. You have to establish that there is futility in proceeding with treatment ongoing, whatever it is, ICU or non-ICU. Consensus among caregivers, and then taking this consensus to the family as well. Initiation of the end-of-life pathway, which is now fairly well defined, which I will touch upon briefly, and which is, of course, the core of the talk, and how are we going to look at documenting it. And symptom management after that, which is largely going to be supportive, which is looking at what I would call as comfort care, or moving from the concept of cure more into the realm of what is called as care in terms of tender loving care, or more in terms of the comfort aspect of it. So the first question, establishment of futility of care. Now this has to be recognized, of course, generally by the primary physician, and based on generally subjective, but there are some objective criteria on how you would look at. So some gross objective guidelines would be life expectancy not expected to be beyond a certain limited period of time. Any condition where the clinician can predict that the chance of a meaningful survival, again quality comes into QOLY as we call it, very, very important for a purposeful life. Post-cardiac status, poor neurological conditions, and when we talk about neurological conditions, it might even mean neuromuscular disorders. Need not be necessarily only the brain part of it, not only the cognitive, but even the neuromotor or the motor sensory part of it. And of course, brain dead patients who are not suitable for organ donation. Now, specific criteria can be derived from specific specialties. Oncology may have their own criteria. ICU, of course, There is no criteria for futility of care per se, but you would probably look at Apache, severity of illness, or something where you have tried and a limited therapeutic trial for 48, 70 hours, and you think things are not progressing, then that is something you can look at. Example of a documentation of establishing futility of care. This is derived from AIMS, of course, which is based on the document, and I have not shown the Manipal document. We are just in the process of completing that, so I was told not to put it out, so I have not put it out here. The consensus among caregivers is the second part of it. So first you establish futility, and then you talk about ensuring that there is consensus among all the treating teams. The closed open ICU debate will come here, of course, and this is where I think you have to ensure that all of them come on the same platform, the caregivers I'm talking about. And this could also include allied services. It need not be necessarily doctors. In a better healthcare facilities, you talk about the nurses being convinced about it. So it's also important that you take the allied healthcare workers along with you as well. So some basic steps for coming to consensus is that you have to ensure that there is mental competency of the patient. If you're going to start involving the patient, there has to be proof that patient is mentally competent to take those decisions, or else you have to identify a responsible surrogate. Generally, this is not difficult because you have something called as NOK, next of kin, or in the Western world, we call it as next responsible person. It need not be next of kin, it could be a friend or whoever. Proper communication has to be then done in a very open disclosure fashion. That is very, very important, and how you go to document it. So as I said, mental competency establishing very important. If incapacitated, then the surrogate has to take the call. Identifying the surrogate is important. I think in the Indian context, the government of Karnataka has made it very easy, but the law does say that, or at least the draft which is right now in the Law Commission mentions that you can actually go by the same standard protocol that we have for other aspects. Some of this, of course, has been derived by from the Organ Transplant Act itself, what we define as the surrogate or proper decision maker. In the hierarchy, it is as you can see here. Of course, the spouse will be first, followed by children, then parents, etc., etc. You can read up about it. Communication is important, as I said, in terms of what are you going to communicate. You have to communicate that the life expectancy may not be very long. The burden of carrying this risk versus benefit of the treatment, is the treatment going to be more offensive or harmful, or it's going to help? I think that is what you need to talk about. And option of end-of-life care as an alternative has to be given. Now, this is the mandate that you have to come forward and give the family. Now, you can't expect the family to take that call, and this should be based not on financial or any other vested interest. That is very important. Now, you can't give this option because somebody is not able to afford, and you can't give ECMO, you pull the plug, your finance person is sitting on your head, administrator. That's not the call. So the alternative, or the end of life as an alternative, is only based purely on clinical decision. And changing the goals of treatment from cure to care, as I already mentioned, and moving more towards symptom-based management, which is likely to be, which is focused on comfort care, and of course clarifying any myths that the patient might have about the illnesses itself. You might be having somebody sitting in the US who is trying to throw their weight around and giving fancy advices. So these are things which you may have to deal with, and of course ensuring and re-ensuring the family that the prognosis is poor. They need to understand that, come to terms with that, and then only you can actually proceed with this thing. So this is an example of the checklist of what you are going to talk about in terms of how you are going to look at documentation. I'm just giving you a template. You can design your own, maybe you even using AI, Meta, whatever you want, but this is just an example for you. Now, important thing is documentation. As I said, you have to document that the patient was compost mentis to take the decisions. And of course, if mentally incapacitated, who is the person who is considered as the next of kin? Very, very important. And you document all that in various formats. It could be the patient's wishes, or it could be the family's wishes. So accordingly, you would actually document who is the family you have spoken to, and of course, make sure that they consent on that, including the relationship of the consent giver or the surrogate. Following this, of course, you would initiate the ULC pathway. Now, this I've titrated to what we have got from the Supreme Court verdict and what is being given by the different professional bodies in India. So establishing consensus is important, and as I said, with the primary team, then of course with the family, and then you move on to what is called as going through our protocol, which is first you ensure that the primary medical board goes through it and acknowledges and documents it. Now, primary medical board definition, all of you I'm sure are very, very clear. It is has to be at least 2 people who are subject experts with at least 5 years of experience. So generally in an ICU setting, it's not very difficult because you would have intensivist and some other person as the primary most of the time. It could be oncologist, physician, somebody. You could. So that is fairly clear, and I think that won't be very, very difficult in today's world. But of course, if there is discrepancy, then you wait. You would not push your way through. You could probably refer it to the secondary medical board as the guideline goes from the Supreme Court verdict. But if you're not sure, you can bide your time, take some more time before you actually approach the family to say that you are feeling that this is reaching the end of the road. You have to make sure that once the primary board is made a decision, in the next 48 hours, preferably within the next 48 hours, you have one or many meetings with the family. Sometimes it may be more than one. Get all the necessary stakeholders. Sometimes it could be immediate or extended family, but make sure that all of you, if possible, all of them come on the board to consensus. Now, sometimes there could be discrepancies. You may have the third person or a fourth person who has never walked in suddenly come in and start creating issues. See if you can build a consensus. Otherwise, I think it will be largely the what you consider as next of kin, which I already showed you, who are going to be the decision makers. And if they are on board, largely you can go through. And important to go through the model of shared decision making. So give them all the options, tell them the pros and cons, explain everything to them, and make them to be part of the decision as well. Here again, don't put the burden of decision on them. I think that is very important, and that is the meaning of shared care decision making, that both of the treating team and the family are on the same page about it. Once that is done, you would refer it to the secondary medical board, which is a set of at least 3 doctors who are not part of the primary medical board. So it could be an intensivist who was not part of this direct part of the treating team. I mean, sometimes it is difficult because we all work as teams, but somebody who has not been involved, for example, who has never spoken to the family, who has not signed anywhere, and so that will be one of them, and of course 2 other doctors along with this. Now in these 3 doctors, one has to be concurs with the primary medical board's decision. Then the decision to withdraw the medical treatment has to be communicated to the jurisdictional magistrate. That also I think has just been clarified in the case of government in Karnataka. So I think the premise for doing this is now fairly solid in Karnataka, and I don't see why we should not be proceeding this. So I think most hospitals or most clusters are now in the final stages. So we are in the process of finishing our legal validation. Once all that is through, then of course we validate all our legal documents. So this is the checklist that you will go through for initiation of UOLC, and then of course go through the symptom management. Now you can document what is the type of symptom management you're going to. It could be only nutrition, it could be pain relief, it could be sleep medicines, whatever, nursing. So this will also go through a proper nursing chart where they keep reviewing the sort of goals of therapy every day or on a day-to-day basis, and of course document what is being done. So in summary, I think establishing futility is the first step. Second is of course get through a consensus with the primary team, which is going to be the primary medical board for all practical purposes in the Indian context, and then you get the family on board on what is called as the shared decision-making model, and go through the secondary medical board, which will be 3 doctors not related to the primary medical board, but with a similar designation that they will have 5 years of subject expertise, one of them being nominated by the chief medical officer, and then of course you draw the goals of therapy in terms of the finality of how you are going to do. And again, this is not going to be the end of the road. On a day-to-day basis, you are going to review the chart. So it's not like once you finish it, you dump the patient in the corner of the hospital and walk away. So you'll have to give the choices. You do it in the hospital, do it at home, keep monitoring these. So it's an ongoing process. So as we said, a brain dead patient is very precious in the ICU when you are talking about bridging them to a harvesting for organ transplant. The same thing does apply for the ULC patient as well. Thank you very much. Sorry if I exceeded the time.
Thank you, sir. Are there any questions on the last 3 talks? Any comments from the moderators?
Yeah, as I think there are many students here, as we could see, both all the 3 speakers, they were very passionate about their talk. So much has gone in, especially the end of life. Basically, as he said, futility, even we as clinicians in the ICU, we can also consider, but there has to be a consensus with the primary team. This is very, very important. That has been explained detailedly. And Pratibha was... No, Pratibha, though as she said, she's youngest in the ECMO clinician, but it was fantastic actually, because knowing the things normally, conventionally, I think all of us will be okay. But beyond that, she definitely stressed upon many of the other indications which we should be considered. There may be a rare scenario, but ethical aspect, definitely it's very important. I still remember, I worked in MHB with Dr. He will still remember, there was one patient who was brought by one of our youngest intensivist. He was saturating 55. He was intubated, proned, but there was a significant pressure because I think we were 3rd or 4th ECMO old. He said ECMO. That patient went home because yes, we were in the learning period. We didn't know much actually. I think none of us experimented with him. He did well. In fact, I met him in Ballari, Pavan anta hesru. So amazing. It is very important. All of us at the end of the day, we have to be ethical in our practice. This is my comment. Thank you.
So this is my imagination. See, basically now there is a bigger horizon happening for ECMO. Like, ECPR is happening now. As you said, the organ donation. I believe there is a big business potential also. I can see that there. Because each and every death, there is going to be a big business and things are like going to happen. So regarding the ECPR, the issue I can see is that, one is that the accessibility. Supposing I am arresting it, maybe around in the city somewhere, I'm an average guy. So the people has to reach me. That one thing. And even if they reach me, the cannulation has to be fast. There will be a lot of demand for the extremely fast cannulation because I don't have any experience at ECPR, but obviously our cannulation will take around maybe 1 to 2 hours or whatever.
To run the ECPR program itself, the criteria is like it should be an high volume center.
The cannulation has to be extremely fast, whatever, even if they do that. Third thing will be a lot of issue with the money point of view because ECMO at the moment, at least the corporate level, including our hospitals, maybe around at least, we used to be around 10 lakhs, around maybe 5 lakhs. People can say at around 1.5 lakh per day sort of thing. Many people may not be affording. So now we imagine after 10 years, whatever, like there. So suppose every person is a potential organ donor. So the discussion will come at such a level that, it is better to have some organ rather than no organ. It doesn't matter, I am 85-year-old, somebody is 40-year-old. People just want to get an organ, that kind of thing will happen. So the people rush to the spot. So supposing hospital X, see, it has to be done by the government. Obviously, government will not be able to, the logistic, even at the private level, you can't do that in that massive level. So supposing I arrested him, I am a poor guy. So some hospital X is going to rush to my spot. And obviously, they snatch me away, whatever you call to their organ center. So I don't think they'll be expecting me to donate this one. So I also expect some kind of a reciprocation. You know what I'm trying to say? I think it is going to make a big, rewarded, kind of every death is a potential, organ donation, and I think there is going to be some kind of a business will happen, knowingly, unknowingly, even, maybe whatever, ethically, unethically can happen. That's what I am. Yeah. And another thing is with this logistic, the thing is that lot of there could be ECMO department need to be there actually because, obviously, my biggest experience was that obviously Sunil Karan and our team, whatever Justin and all, in the Manipal, during the COVID time around 8 patients are very successfully, very closely monitored by your team, whatever is there. But when every death is a potential organ donor, it should be a department of ECMO. Already I know there is a department of ECMO is in Chennai Apollo, there. But I think the new department has to be open and, kind of only cannulations and some ECMO hospital and transplant hospitals will be, the transplant hospitals will come up and they'll be just, rushing and, I think it's a big business opportunity I can see. Unfortunately.
I think there are two different facets to it. Now, the talk was largely ethics of ECMO. Now, unethical practice can happen irrespective of that. Now, if medically there is an ethics on it and you think that a particular organ is salvageable and the family agrees. See, all this about normothermic reperfusion, we are talking on the context of family agreeing. So I don't think we will be getting into the realm of, as you said, somebody can rush patients here, there, everywhere, even with or without ECMO. No, what time? Huh? That will always be there, but I think what we have to be very clear is, at least in the context of the talk, was that where do we draw the line in terms of ECMO? Yeah. So I think the NRP definitely is a good tool as long as you know that you are going through the sequence, and it's very well cleared. I think with the DCD now becoming a proper definition in India, if it comes through, then you know. I mean, you are talking about withdrawal. You have a 5-minute lockout. In most countries, use 5 minutes as a no-touch time, and then you would move on from there. Now, after that, you start regional perfusion. I think it's still this thing because it's very clear. Again, when you talk about NRP, the brain doesn't get perfused. So there is no question about that. So I think the people taking whatever we explained can happen either way, but as long as we know that this is the boundary of it, this thing. So I think so.
And really, what's your take on this probiotic on immunocompromised people, the so-called neutropenic sepsis and other?
I think in immunocompromised, I said one has to be cautious and the tendency is not to give. But prebiotics you can give. Prebiotics is a fiber, basically. So probiotics, you have to be cautious. Because gut is already, dysbiosis has happened. So it's a problem.
You will have to keep doing it, no? Come on. You can take over.
Good evening, all. My name is Shakti. I represent Antara. So I think basically we are a transition care center backed by the Max India, Max Group of Delhi. And I would like to thank Dr. Pradeep Rangappa for giving us this opportunity. I'd like to basically brief on Antara. Antara is a company backed from the Max India group from Delhi, and we have launched one of our first transition care center in Banagata Road, around 83 odd beds. Basically talking about transition care which patients undergone post-surgical care. I'll give it to a doctor who would like to present one of our case which we have taken from the ICU and managed him at our center, and that's all. Thank you.
Thank you so much for the time. I'm Dr. Divya. I'm one of the doctor in Antara Care Center. And here I'm going to present a patient who is 32-year-old gentleman. He met with an RTA. At the time of admission at Apollo BG Hospital, this patient had multiple issue, head injury, clavicle fracture, facial injury, hemo and pneumoperitoneum. So primary management they have done at the Apollo Hospital, and after that, after stabilizing the patient, they have referred to Antara Care Home. At the time of admission, this patient was on multiple tubings, and depending on the patient's condition, we have created a care plan. In that, all the tubings management were there, and same like that, physiotherapy and all the rehabilitation specialist came and evaluated the patient's condition. And after that, we have conducted a counseling session with the family members, and we have explained them, okay, this is our plan of management we are going to initiate for this patient. First few weeks was a little bit challenging for us because patient had multiple episode of infection, mainly which was from the UTI and TT. Then after 3 weeks, we started developing improvement in this patient's condition. And finally, with the help of rehab and physio people, he started walking, and after 4th week, removed all the tubings. And at the time of discharge, the patient was able to walk without support, all the tubings removed. After discharging from our center, they directly went to hospital, TT tube removed done. After 1 week, cranioplasty also done. Last week, this patient visited our center. He came back to his normal routine life. He is able to do his day-to-day activity without any assistance. So, yeah, this is one of our successful story. Thank you so much.
Thank you, doctor. Thank you so much.
Gratitude from Manipal Group for helping us in organizing this academic event. And we wish to have ongoing collaboration with Antara. Thank you so much, sincere gratitude.
I now call upon Dr. Radha, Senior Consultant Intensivist from Ramaya Memorial Hospital, to speak on innovative therapies in ARDS. I request Dr. Pradeep sir to hand over the token of appreciation to Dr. Sunil sir.
Namaste. So at the outset, I would like to thank the team BICEP for this opportunity. So my talk is innovative therapies in ARDS. So I'll be trying to address this with respect to need, challenges, what we have in ARDS, the current treatment, and the reality with respect to innovative therapies. As we are all aware, ARDS is a complex syndrome. Even with almost 5 to 6 decades of research and understanding, the mortality is very, very high. This is 2014 data. Mild, almost 34% of the patients die. Moderate, it's around 40, and severe, it is 46. However, post-COVID, overall mortality is found to be around 50%. The current treatment or the strategies what we have is supportive therapy and protective ventilation, in which low tidal volume has a survival benefit. The other strategies which have shown some survival benefit would be neuromuscular blockers, that is the accuracy study, then Caesar, ECMO, and prone ventilation, that is the ProSeva study. So the mortality remains to be very high. It is very important for us to understand the historical and the practical perspective of ARDS definitions with respect to the implementation or the research into innovative therapies. Because in 1967, Ashba first time described 12 cases where predominantly the ARDS definition was depending on the clinical scenario only. However, there were other causes which were not addressed. Subsequently, there was more objective definition, that is the Murray definition, where we had lung injury score. However, there were many gaps even figured out in the Murray. Then subsequently, we have the AECC, and Berlin definition was more or less tried to address the previous gaps in the AECC. Then in 2023, we have European Society, where considering the resource limited countries, it included HFNO, USG, and the SpO2, FiO2. So the latest definition what we now have is the new global definition. Why I am stressing upon or emphasizing on the definition is because identifying a syndrome like ARDS is not very easy for the clinicians, because it has to be identified. If we identify, probably we will try to address the problem earlier. So new global definition does acknowledge the heterogeneity of the ARDS. It is one of the important factors why we have failed as clinicians or researchers in developing the appropriate treatment strategies, whether it is ventilatory or non-ventilatory in the ARDS. So the risk factors, timing chest imaging remains the same for all the scenarios. However, oxygenation, depending on whether the patient is intubated, non-intubated, or resource limited centers, also is included. So it does acknowledge the heterogeneity. The other aspect what we all have to be knowing before we actually go into the innovative therapy is the pathological changes in ARDS. So this also has significant implication in the treatment strategies, because the pathological changes doesn't remain pertaining to the lung. Even extrapulmonary immunomodulation, immunoinflammation, even immunothrombosis, which we all have seen in COVID, is also very important. So the pharmacological strategies have to be targeted to this. Though it is theoretical, that's how the treatment strategies evolve. coming to the heterogeneity, it is very important. As I said, even after 5 to 6 decades of research into ARDS, we fail in significant pharmacologic and even ventilatory strategies with respect to ARDS management. So there are many components into heterogeneity, whether it is a spatial heterogeneity, because as we all are aware that it is the baby lung concept. So the lung in a given patient with ARDS, even if the risk factor is the same, it is not homogeneously affected. So there are areas of damage in the lung in a given patient or in a given set of patients having the same risk factor is different. This is very, very important because it has therapeutic implication. Then coming to the biological heterogeneity, we have direct injury which is causing predominantly the epithelial damage, and the indirect injury, especially the extrapulmonary causes of the ARDS which result in ARDS. So whether they behave in the same way as if we do a particular ventilatory strategy or a pharmacological therapy, because all this understanding or our evolution of understanding is better probably with the COVID. Then functional heterogeneity is also known in ARDS because different patients have different gas exchange and compliance across different risk factors. Because this is very, very important. It's not that like all our patients who are prone will respond the same way. In fact, even if it is done early, which is in severe ARDS, 70 or 80% of the prone ventilated patients do respond. The other 30 may not respond. There are other factors probably which we haven't understood. So heterogeneity is a very important factor which is attributable to lack of effective, efficient therapies in the ARDS. So we are still understanding, probably COVID has helped us. As I said earlier, it's not that a homogeneous treatment strategy will help in all our patients with the ARDS. When we are initiating, what risk factor has led, what the other factors also do play a significant role. So there is a phase-specific therapeutics or a variable response to a given strategy in the ARDS. So with this in background, I'll go to the actual topic. So it's again important, sorry I forgot. So one size fits all, this concept doesn't hold good in ARDS. That is the reason we have now personalized medicine or patient-tailored strategies and the precision medicine. So in ARDS therapy, innovative therapies in the ARDS, we have cell therapy, targeted therapy and the personalized therapy. In the cell therapy, we have mesenchymal based therapy, non-stem cell based therapy, cell component therapy and plasma therapy. So mesenchymal based therapy, basically it will help in immunomodulation. These are the proposed mechanism actually, regenerative properties and barrier function recovery. Especially in the preclinical and few of the clinical case series, it's been found that mesenchymal based therapy does help in the patient. In fact, one of the researcher has followed up after instituting mesenchymal cell therapy for 2 patients and they did well over a period of 5 years. So it is still in the research or probably phase 3 I can say. There are many limitations or many factors which needs to be addressed with respect to the mesenchymal cell based therapy. That is the source, because we have adipose mesenchymal cell therapy or bone marrow or umbilical cord also. So which source suits which set of patients, it is still debatable or controversial. So we are not definitive about that. The second aspect is the delivery of such therapy, whether it has to be injected to the lung or whether it has to be intrabronchial or it has to be intravenous. So this aspect also needs to be addressed. And the timing, which phase of ARDS, as we are aware, the pathophysiology of ARDS spans over 1 to 2 weeks, whether it is in the exudative phase, whether it is in the fibroproliferative. So these are also not very clear. Probably theoretically we can say maybe in the early part, but this also has to be defined and researched better. And for whatever it is always very important that we should know the pulmonary microenvironment for instituting these kind of cell therapies. That is also in the research process. So apart from the mesenchymal cell therapy, we have the non-stem cell based therapy and the cell component therapy. In the research phase, what they have figured out is there are certain advantages of this non-cell component therapy with respect to the, or in comparison with the mesenchymal cell therapy. That is, this cell component therapy has low immunogenicity, prolonged in vivo sustainability, high delivery efficiency, and low risk of iatrogenic tumor formation. However, as I said, this is whatever the data I am telling or the information, this is from the 2024 Nature, but still these are all in the experimental or clinical observational studies. So actual practice we still don't know, but these are all very rewarding though. Coming after the cell therapy, we have the targeted therapies. In the targeted therapies, specific molecules associated with the disease like neutrophils, GM-CSF, they have been, or TNF pro-inflammatory markers have been targeted. Even the antibiotics also, especially the macrolides where the azithromycin, other macrolides have been tried. Again, these are all in the experimental or in the theoretical background, what we can say. But actual clinical practice, we need more evidence, robust evidence for the recommendation to be made or guidelines to be made by a specific body and into clinical practice. Personalized therapy, I think Dr. Sandesh did highlight. Basically, here also, this is all like acceptable, but how much it is bedside possible, still we don't know. But probably because it is a heterogeneous disease, still this has scope. But how do we identify a particular patient who may not respond or who may respond, whether there is ethical consideration? Suppose a severe ARDS is there for a different cause, whether I am going to prone or not, because it has shown survival benefit, and in our experience also we have seen. So whether it is to be done or not to be done, or like we need to individualize, these are all the things which we need to address. Probably, I think over a period of time, maybe with more evidence, we will understand this better. However, with respect to personalized therapy, what they say is, rather than targeting the tidal volume, driving pressure targeted lung protective ventilation is the key. So my take home message would be, ARDS is a complex disease syndrome. So predominantly heterogeneity is considered to be one of the factors why we lack effective, efficient therapy. The innovative therapies include cell therapy, non-cell therapy. Precision medicine is also there. But I would emphasize that we should be perfect in our, or at least we should aim for, or we should reflect on the basic care, what we know, what we have as clinicians manage, be right. Then we can always think of the other aspects also. And the other aspect what I would stress upon is, we have to be holistic clinicians in the ICU as intensivists. It's not only the managing the ARDS, even the post ICU syndrome is also well known, because these ARDS patients stay with us for a longer time. So it is very, very imperative as clinicians bedside managing these patients, we have to be giving them psychological support also, and we should always care about these things. So this is my emphasis, or what I would stress upon. Thank you for this.
Thank you, ma'am. It was an interesting talk, as the cell therapies are going to be a promising one. I now call upon the next speaker, Dr. Ajit Kumar, sir, lead intensivist at Astor Hospital, Whitefield, to deliberate on role of PET-CT in non-oncological critical care. I request Dr. Chinnadurai sir to moderate the session, sir.
So good evening. It's already running late. So I am worried that I don't have anything very updated or exciting from my discussion. I'll just go through fast. So I'll be making a small introduction. Then use of PET-CT scan in non-oncology critical care, and finally the take-home message. So basically the the gallium scintigraphy has been used to detect inflammatory foci since 1970s. So the gallium accumulates both in malignant tumors and inflammatory tissues, and gallium scintigraphy is still used as a component of workup strategies for patients with fever of unknown origin. Now the introduction of an FDP, that the fluorodeoxyglucose positron emission tomography has, that has happened in 1990s. And an FDG PET is a functional imaging modality. What I mean to say is that we are talking about PET CT scan. So it has got two components. One is about the CT component. The CT is very useful to delineate or resolve the anatomical aspect of the organ of the body. And obviously the PET scan is positron emission tomography is going to be useful to assess the functional aspect of the at least at the tissue level. So naturally what we are doing with the FDG PET scan is that we are trying to see the areas where there is increased uptake of this whenever the tissues are metabolically more active, those areas there is an increased uptake of the FDG glucose is happening, and we are trying to find out these areas and we are trying to identify the abnormalities. So basically it's a combination of functional as well as anatomical aspect of the particular organ that we are scanning. So now we have been talking about gallium scan. So obviously the PET CT has got a lot of advantage, higher sensitivity and specificity. There is a faster imaging time is much faster. It is more versatile. And we already mentioned, because when you say PET CT, the PET is going to give you a functional resolution, and then obviously the CT is going to give you more of an anatomical resolution. So the PET CT has been known to be useful, especially for diagnosing, especially in the ICU settings, fever or inflammation of unknown origins, bacteremias. So bacteremias, I'm not very sure the PET CT will be able to identify the bacteremia, but obviously it can indirectly find out, especially the metastatic, the spread of the inflammatory lesions all across the body. So it may be able to find out indirectly it may be able to give you a hint about bacteremia. Fungal infections, bone infections are very useful. Vascular graft infections, prosthetic joint infection, many times we may not be able to say. Some collections are not very difficult to say whether it's infective or inflammatory. And endocarditis, there is very interesting, because especially studies have shown that especially in culture negative endocarditis, see, sometimes many of the time the cardiologist may have a doubt when you see a abnormal, so-called vegetation, whether it's a clot or which is the vegetation. So you need to find out whether, when you are ambiguous about the diagnosis, the FDG, the PET CT may be able to identify, these, whether there is an infection happening there or not. That may be more useful in those conditions, and especially in prosthetic valves. And another thing about the infected, what are the challenges? So in my experience, maybe every year, I might have done around three PET CTs, the entire thing. So what are the real challenges here? So the perceived complexity of planning, preparing and transporting critically ill patient who receive circulatory and ventilatory support, presence of multiple medical devices, catheters, and complicated inflammatory conditions which may interfere with the interpretation of 5-deoxy-glucose, because those areas also, sometimes it may also take, there is an increase in metabolic activity may be there will be some sort of a pseudo uptake can happen. Again, it's going to complicate the entire thing. The evaluation of infective foci in sites of physiological tracer update, brain, so urinary tract, skin, or areas under the resolution power of the scanners. There is, whichever lesion is small blood vessels, a lesion is less than 5 millimeter of size. So the second CT, when it's not able to resolve, in areas where the size is less than 5 millimeter, there is something called a digital or long axial field view tomography, which I don't have any idea, but I just mentioned just to be aware of that. So basically, these conditions is difficult. These are some of the challenges which can happen in PET CT. And reduced specificity in discriminating between infection and non-specific inflammation. I will say that the overall sensitivity of PET CT may be up to around 70 to 80%. Whether the specificity and the sensitivity and specificity, even the negative predictive value may be around 80%. An effect of hyperglycemia, because whenever you have an hyperglycemia, the sugar in the tissues, it is going to, whenever you have a sugar in the tissue, it is going to make the contrast less contrast between the FDG and the normal tissue. So naturally, you need to have the blood sugar under control, preferably less than 150, but at least less than 200. That is another thing which is very important. And in case of renal failure, there is a reduced clearance of the radiopharmaceutical causing a higher background activity and lower contrast between pathological lesions and background, that's also expected. And obviously it has got a longer scanning time. And patient who is having, if you are going to look at anything in the heart is also another organ where there is a lot of, metabolic activities happening. So it is likely that, you, in those patients who are undergoing any evaluation of the cardiac thing, you are looking for any kind of a cardiac sarcoidosis, cardiac myocarditis. In those patients, patient should be having a no carbohydrate. I written low carbohydrate, but some other people, the people are telling it should be no carbohydrate has to be there. As I already mentioned to you, it is lesser the glucose, the more the contrast. Especially heart, already the glucose may be active there, so the contrast is going to be it is going to be less contrast. It is going to be more difficult to identify. So those patients will have a strict sort of glucose control. Should be a non-carbohydrate diet. The European, the guidelines say that patients should fast at least for 6 hours, before FDG PET, and no glucose infusion allowed. We all know that. And the major issue which I can see is that you cannot do the PET scan if you want to do it in night or maybe at any time. So maybe in weekends it may not be possible. All these issues are met with the PET scan, and the cost is also going to be higher. So the specific use of any kind of anything which is very interesting, PET CT. I went to some kind of a reviews on that. So this is about some systematic review. It's a seminars in nuclear medicine. I think it's in 2023. So basically, they are mentioned about it's all in the experimental level. I will say the pathophysiology of the lung. I don't want to read out everything. So basically, it has been told that these areas or the scan can identify areas of neutrophilic accumulation, neutrophilic inflammation. So these areas, especially these are more associated with areas of ventilator-induced, lung injury, and especially sickle cell anemia patients. You can have an acute chest syndrome. You can find out, what exactly is happening. These diagnosis can be a little bit more clearer in these patients, the acute chest syndrome, sickle cell anemia patients. And in acute neurological disease, something called interictal continuum. Interictal continuum is a situation where, whenever a patient is having a status epilepticus, you control, you achieve the burst suppression. But in between burst suppression, even during burst suppression, even neurologists can be confused to say that there are some kind of activity still happening. They are not very sure whether it's ictal activity or non-ictal activities. So when 18 FDG update factor are absent during the burst suppression, the authors believe that this is primary ictal pathology. So when there is no activities happening, it's an ictal pathology. That's what the studies have shown. When there is increased uptake is happening, persistent uptake is happening, but that's a non-ictal pathology. So you can identify in this case of interictal continuum whether it's a kind of a related to ictal or non-ictal. That is one thing which has come in the recent literature. And sometimes when the glucose delivery higher metabolic rate was associated, when you find there is increased uptake, is that there is increased metabolic activity, then it is associated. Then that means that there is a reduced blood flow and oxygen metabolism. That is one thing. So it can be indirect evidence of a brain ischemia when there is a metabolic activity is supposed to be in the higher side. That's especially with the head injury patients and all. And infections of unknown origin, it has been useful because I don't want to read out everything. I will approximately say that 80% sensitivity, 80% specificity, maybe around up to around 80% on the negative predictive value in fever of unknown origin, which is supposed to be very much useful. And these are different specificity and sensitivity in a septic shock of unknown origin, severe sepsis of different varying specificities are there. There are some people as others have tried to find out helpfulness. Around 60% helpfulness is whether it's really helpful after doing the scan. Did it make any difference in the outcome? And especially, infected endocarditis, I already mentioned to you, especially culture-native infected endocarditis, where you have a doubt, even in doubt, when you have a cardiologist having doubt between clot versus, vegetation, it can be used, which I already mentioned. And one thing I want to introduce to you is that there is always, we have, the PET scan is all across, the PET CT scan. There is something called as, leukocyte PET scan. That is an 18 FDG labeled leukocyte PET scan. So you are labeling the leukocytes, you are taking the patient's blood, around 20 cc of blood, and you are injecting and you are taking the PET scan. This is supposed to be highly sensitive, and it has got more resolution. It has been known to find out more conditions. I think in India there is only three centers are there. Maybe the first center in India would have been a PD Hinduja hospital, and I think in PGH Chandigarh also it is there. What I understand from my colleagues is that because the only issue with this is that you take the blood sometimes, after you inject into the patient, unless you take it in a sterile manner, there is a chance of, infections are there. This is supposed to be much better. The PD Hinduja was the first hospital to get this, the the leukocyte label, leukocyte PET scan, FDG label leukocyte PET scan. So this is, the studies have, so my take home message is very simple. Studies have shown, high sensitivity and specificity of PET scan in the diagnosis of fever of unknown origin, where it has got a high negative predictive value, which I already mentioned to you. Leukocyte label FDG PET scan has got higher specificity while maintaining the sensitivity and resolution, providing anatomical functional information. Is supposed to be much better, in identifying any kind of foci sepsis, especially when you are, suspecting foci sepsis. It's supposed to be superior to simple PET scan. There are certain limitations and challenges in executing PET scan for IC patients, and decisions should be made on a case-to-case basis. So thank you very much for your patient listening.
Thank you, sir. We'll take the questions at the end of the sessions. Now I call upon Dr. Karthik sir to for a panel discussion on Green ICU, is it feasible? And I request all the panelists to be seated in the front rows, please. Dr. Rajendra Kumar, intensivist from Manipal, Hebbard. Dr. Vijay Reddy, intensivist from Manipal, Millas Road. Dr. Gopal Krishna, intensivist from Manipal North Side. Dr. Varun Bhairappa, intensivist and HOD from KIMS. And Dr. Zaid, intensivist from Shifa Hospital. And Dr. Venkateshwaran, intensivist from Manipal, Millas Road. Mics.
Last questions and you answer.
Okay. Hope all are still awake. Right. So this is the last part of the session. It was supposed to be for 12 minutes and we thought we'll extend it for up to 20 minutes, but now looking at the crowd, we'll tailor it somewhere in between. Okay, so the concept is about Green ICU. How many of us are aware of the concept of Green ICU here? Great. Any guesses on why this slide has come up here? The reason is we have made our lives too complicated. So initial days when a patient used to come to the ICU, we remember if any procedure was being done, it was done with all reusable materials. For example, the gown was reusable, we use it, send it for cleaning, it used to come back, we used to use the same thing. And much earlier it used to be even worse, where we used to all wash our hands, clean it with a towel, etc. I'm not saying that was the best thing, but what I'm saying is we need to have a mid path. So in the whole bargain of doing disposable things, we have made our lives very complicated. Tissue for everything, disposable gowns, a lot of plastic is being used. So all of these are definitely damaging our environment. So this is where the whole concept of Green ICU is evolving. And this is not new. If you look at the timelines, the whole thing about sustainable development started in the year 1987. And then by 2000, a One Health concept came in. 2015, the United Nations agreed on 17 objectives, of which 7 were healthcare related ones. And 2020, it got better. In 2022, 10 Spanish hospitals took up the initiative to convert themselves into a green unit. So green is an acronym which says Greater Environmental Sustainability in Intensive Care Units. It's a multidisciplinary initiative to design evidence-based guidelines. So from evidence-based medicine, we move to patient-centered medicine, and now it's our responsibility to move to planet-centered medicine. So this is where our expertise comes into role. Okay, so ESICM has put forth this paper wherein they've looked into the clinical care, the research and innovation, awareness and education, and ESICM as an organization, what it has been offering in terms of Green ICU. Okay, having gone through the introduction, I think the first question comes to Dr. Rajendra. So, Dr. Rajendra, what are your thoughts on Green ICU? Do you think we can call ourselves as a Green ICU, what we are practicing?
Yeah, well, good evening, everyone. I know Karthik said the time is short, but I'll try and answer as fast as I can. I was supposed to come with a T-shirt which has this message, but somehow I forgot to wear the T-shirt. But I'll read out the message loudly. It says, turn right, think right, do right for a better world. So I've been trying to work a little on this with whatever capacity I have. And then Green ICU was somewhere related to that, so I just thought I'll pass this message. Well, I mean, all of us have only one address, that is planet Earth, and then we need to keep it for our future generation. I mean, a lot of things have been spoken about carbon footprint, sustainable living, but the work done towards that is very limited. But fairly, there are a few examples in India where they have done a lot of work. Like every industry has its own footprint, I mean carbon footprint. Our health industry is also doing the same thing, but probably a little less. Like how the treatment modalities have advanced, facilities have improved. Parallelly, the resource utilization has improved. I mean, similarly, the waste generation also has improved. I mean, a lot of waste is generated. So that is how, as Karthik said, we have been trying to follow the guidelines, or probably stretching too much. So little about, following the Western guidelines where the resources was not a problem. And a little by, the, companies driven thing, saying that, patient safety, infection control, all those things have put us into, using a lot of things. So in ICU where, this energy utilization is less, or, the waste production is less, can be considered as green ICU. Our ICU is green. At present, I don't think so, our ICUs are green, but, those who have worked in Western countries, probably they might say that, probably we use less than what they use, resources and, the waste production maybe. But we can definitely put in effort to make our ICUs greener. I mean, it's a big task, but slowly, small things can be put into the practice. And for that, the first thing is, we need to create a team and get people into the team who are interested to work towards it. Okay, I mean, that is possible. Well, I'm not going to give many big examples, but if I have to tell you small examples, 30 seconds. 15 years back when I was working in one of the missionary hospital, I started collecting the glove papers and keeping them next to a telephone. So that, when the phone comes, if they have to communicate something, they don't have to pull up the, A4 size paper from the printer and write down on that. They started using the glove paper to write. Over a period of time, other people in the hospital they saw, and the dialysis team, the OT, everybody started sending the papers to the ICU. And at the end I have collected the papers, stitched them here, made a book out of it and used it as a book, okay? The glove paper. The second thing is, the disposable pens what we use in the thing. So whenever I want to gift pens to the staff, I give a pen and tell them there's a refill, 2 refills I'm giving you. If you want more refills, ask me, okay? The third example, well, it is not about the patient care, but I've told my staff, in my hospital there are only 2 floors. I said, if you don't use the lift for your own movement, for the patient care, you have to go through the lift. If you don't use the lift, at the end of the month, you can come and take 200 rupees as a gift from me. Okay, so this was told to them in the last Christmas. Till now, only 2 people have taken, and in that one has been consistently taking it every month. Okay, so these are the methods to reduce the electricity, the consumption of the energy. There are a lot of things which we can start. Once we start, probably we'll get more interested in doing our ICUs as green ICUs.
Yeah, I can vouch for Rajendra's word because we've been colleagues way back 25 years ago, and I've seen him actually practice what he's telling. He's very passionate about this thing, and completely agree with him. So all of the problems started with the COVID pandemic hitting us, because that is when we saw a lot of these disposables coming into the arena. So we have to consciously make sure that we start reducing one after the another by one or the other means. I think Dr. Vijay is not there, Allah? Okay. So the question for Vijay was, what are the implications of climate change in the ICU? I'll just summarize this because Dr. Vijay is not around. So climate changes in the ICU patients can be all of these. So one is heat-related admissions. As the global warming has been a problem, an ongoing problem, we see a lot of admissions coming because of tropical issues, because of infections related to the tropical related diseases. Natural disasters also can cause a lot of injuries. Hospitals can be submerged in floods. There can be a lot of fire accidents, etc. So ICUs get overburdened with these sort of patients because of the natural disasters. Microbiological patterns also change with the evolving climate changes. So that is very commonly seen. the heat will create a lot of these resistant organisms. So that's how the sensitivity patterns also change. Social structure changes becomes very common because low socioeconomic status patients can get more and more burdened with a lot of diseases like tuberculosis, leprosy, etc. The high risk behaviors can cause a lot of accidents. The heat itself can cause a lot of cerebral irritability. Mental health changes are very commonly seen. So these are all the problems that we can anticipate when the climate changes, and they are all burdens to the ICU. ICU admissions go up, and this is how we can see a change going further. The next question to Dr. Gopal, how do you measure sustainability, Gopal?
Yeah, so basically 3 methods to measure sustainability in ICU. One is called LCA, that is life cycle or life assessment, life cycle assessment. Yeah, life cycle assessment. So any product which is used in the ICU comes obviously from the nature. So you see for paper, for example, paper, you have to cut trees to get paper. So any product will be assessed by how much of carbon footprint it is causing, and you try to reduce on that. You try to see where are the hot spots. For example, plastic aprons, reusable gloves. So you try to measure how much of environmental impact it's causing. And second is called material assessment, or what you say, what are the materials which come into the ICU and what are the materials which go out of the ICU, material flow analysis. So you see where you can recycle these materials and try to save on those things. And waste audits. So you can do audits of how much waste is being generated in the ICU, how much waste per patient, and you extrapolate it, how much can be reused or recycled. So that is how you try to assess each intervention in the ICU and try to see how you can try to reduce their or recycle or reuse these things in the ICU.
Yeah, thanks. And next question to Dr. Zaid. Is there any means of evaluating the current state of the ICU we all work in?
My answer would be an extension to what just Dr. Gopal said. If we had to, the very fact that we are sitting here is that we get charged up about what green ICUs are and start implementing things in our own ICUs. For example, like he termed life cycle analysis, material flow analysis, and biomedical waste audit. So practically in our ICUs, we can go back, first sit with the procurement team, I mean the purchase manager of the hospital, and see what are the materials which are flowing in, how many kgs or how many boxes per month we are utilizing in terms of disposable gloves, disposable aprons, and what all disposable items which we use. And secondly, we can do the material flow analysis by calculating which department of the hospital is consuming it the most. For example, the operation theatre and the ICUs are the demanding departments. These are the departments which consume a lot of consumables, which have a lot of carbon footprint. Then next, we can go and find out what our current water usage is per month, and what is the electricity consumption, what is our electricity bill. And as Dr. Gopal said, biomedical waste audit, because not everything is hazardous. We can further segregate, of course keeping with due regards to all infection control policies, we can segregate the biomedical waste into non-hazardous recyclable material. For example, if you take antibiotic vials, they are basically non-infectious, but we throw them into the glass bin and it goes for incineration. That causes a lot of carbon footprint. So we have to basically go and sit with all the stakeholders, right from the purchase manager, the material manager, and then our biomedical waste team, and we have to sit and see where exactly we can plug all these things. So that would be my take for this.
Yeah. So yeah, it's predominantly on these lines that you were just speaking about. So material flow analysis, waste audit, life cycle analysis, procurement data review, and identify low value practices, whether we are doing the right practices or not. So I think Dr. Varun, you've heard about the Green ICU team. So who are all a part of the Green ICU team, and can you just tell them what are the roles of each person over there?
Actually, the concept of Green ICU team came from mainly from the Australia and the New Zealand, where the first concept of it started. So they started thinking the effect of the ecological footprint, or we're talking about the carbon footprint, ecological footprint, what a patient, a bed from an ICU causes to the environment. So it was very hardening to hear when they saw the carbon footprint, almost 150 kgs of carbon equivalent is it's done from a patient on a ventilator, a septic shock patient. So the 150 kgs equivalent of carbon dioxide is equivalent to driving a car for 1,000 kilometers. So that is the impact of ICU on the environment, and that's where most of the studies started coming in, how we can reduce it, and that's where they formed this Green ICU team members. So the team, as it's there on the board, it's a big number, but we should not get disheartened by saying that we need all the members. It's not possible in a place where you can't, where they're resource limited. At least few members to initially start off would make a big difference. So the basic thing is the nurses. The nurses are the one who's going to be with the patient 24/7. Just by repeatedly sampling the patient, it will also add burden to the environment. Like you test the blood goes to the laboratory devices. The devices will generate heat, and heat is nothing but carbon dioxide, methane gases. So that's the effect. Simple repeated investigations can have an effect on the environment. So when it comes to doctors, so we are in evidence-based medicine. When we talk about most of our parameters are based on monitoring devices. Have we given a thought of what these monitoring devices is going to do on the environment? Again, it's a big question mark. So we say you have to put all the machines generate heat. We are there in an ICU which has cold temperatures. How much will the ACs generate the heat? How much carbon dioxide is produced? And if you see most of our ICUs, the places which most of them is a closed space. And most of the places which does not require AC will also be having cold temperature, apart from the patient also, like consultant room where you don't need such low temperatures. And again, just by variation the temperature, doing a variation with respect to the temperature will reduce the amount of gases produced. So it requires clinicians' efforts, purchase, as we were talking about purchase. So when you're coming to purchase, most of the time we don't know what is the materials involved in it. There might be heavy materials like lead, which when you dispose it cause a lot of biohazards, PVC materials. So all these things, when you talk about the infection control, it becomes a routine, and just for a simple procedure like a central line, how much of plastic is generated and how much is disposed for simple procedure, and imagine the same thing occurs. So procurement becomes important thing, the financial aspect when you see the cost difference, when you do a recycle and the reuse, when you do to a one-time use materials, the difference of cost to also for the administrators becomes it's a good impact for them. So the team members, it's also a wholesome approach, requires many members of the team to act on it. Biomedical engineers, because most of the machines which are worn out also generates a lot of heat, which is again hazardous to the environment. So not utilizing those machines for longer time also is one of the aspect with respect to the environment. So all these aspects has to be looked upon the formation of the team.
Yeah, thanks, Dr. Varun. I think every individual within the hospital environment has a role in this green team. So that is the thing that we all have to carefully look at. And this chain has to be continued. Any break in the chain is going to again cause problems in the whole thing. So Dr. Venkatesh, I have a question. So we have spoken a lot about these things. What are the practical things that you would like to go ahead with to look at the sustainability initiative? Any practical tips from your side?
Yeah, good evening everyone. So everyone, we know on a daily basis we use many recyclable and reusable things. Many can be disposable, single times we can use. So in this, that gloves, disposable gloves, many of them we use single-use gloves. Nearly, my ICU every day we use 400 to 500 gloves we use per day. So to reduce that, we have to make a clear-cut protocol when to use sterile gloves, when to use that single disposable gloves, and when to use the hand hygiene to prevent the infections. That itself help to reduce almost 10 to 20% of the waste production in the ICU. Apart from that, that isolation gowns, what we use, the surgical gowns, what we use, instead of that, if you use autoclavable surgical gowns, that will help to reduce the waste production. And that infusions like antibiotic, levofloxacin, linezolid, paracetamol, instead of using the infusion, if the clinical condition permits, if you use a tablet form, that will help to reduce the waste productions. And on ICU we use a percutaneous tracheostomy very frequently. If you reuse the percutaneous tracheostomy techniques, tubes, it will help to reduce the waste productions. There are many methods mentioned here. These are all the simple measures will help to reduce waste production in the ICU. Thank you. And at the same time, we have to do an audit and qualitative measures to help to reduce reusable products in the ICU.
Yeah, it's a fine balance that we have to strike between clinical practice, infection control practices, and quality of care that we deliver to the patient. So a balance between all of these has to be achieved so that at least we are in the right track. The next question is for Dr. Vijay. I think we'll just skip it. Dr. Zayed, you're aware of this 3R green team structure. So any thoughts on that?
Yeah, this 3R green team structure stands for, the first R is for recycle team, the second R is for reduce team, and the third R is for rethink team. Now each has got its important functions. Though the function of recycle team is to think what things they can recycle. Like for example, just now I said the glass vials of the antibiotics which are used, or infusion tubings, or CRRT tubings, for example. All these are sometimes not hazardous. So the recycle team has to sit and think what are things in the hospital which are part of biomedical waste which are going, which can be recycled. And secondly, reduce team, which is the most important team. So first of all, reduce your consumption of things which have a high carbon footprint, because each and every item in the hospital as per life cycle analysis has got a number which you can just go to the website healthcarelca.com. You just type, for example, for your endotracheal tube, which has got a carbon footprint, and your laryngoscope blade, whether there is a different carbon footprint number for a disposable blade and a different number for a reusable blade. So you can start sorting out the materials which you use in your hospital which are having a very high carbon footprint, and you can change over to the items which have a low carbon footprint, and as well as reduce the consumption. That is a function of the reduce team. And all these things will be done by a rethink team. The rethink team will sit and balance infection control policies at the one end and reducing carbon footprint at the other end, because always there is a conflict when you have to use reusable items. There is some difference of opinion and it clashes with the infection control policies. So you have to strike a balance. You don't want to compromise infection control. At the same time, you have to reduce the carbon footprint. This is the function of the rethink team. This is what these teams are going to be helpful in reducing carbon footprint.
Yeah, thanks, Dr. Zaid. I'm sure this is easier said than done, but we need to know if any countries have been adopting this Green ICU concept successfully. Dr. Gopal?
Yeah, as Dr. Varun said, I think all of this started in the West, and Australia is and New Zealand. In fact, 65% of New Zealand ICUs and 40% of Australian ICUs are green ICUs, to be as per data from 2020 publication. So,
policymakers, stakeholders, because it's a whole thing. It's because it involves even simple things like an IT, IT persons, like they have to look after the electricity, which looks a very simple thing. Most of the places in the hospital are lit unnecessary when there are no patients also. And, so you have seen the desktops on the hospitals which are on and not in the, it will be in the screensaver mode, which will still be utilizing the electricity when you want it to be off. So that also happens in the ICU most of the times. So these are the things. So that is why the way forward would be trying to involve as many teams. It's a multidisciplinary. It's not only to the healthcare workers. Try to get them aware. And once they are aware, once we start knowing the awareness of it, obviously the research begins. So have a lot of research in it, and that research will come as guidelines. And you can also incorporate all these things as one of a training, requirement for ICU graduates when they know the importance of this in their curriculum. So all these things would be a useful way for a step forward.
Yeah, adopting simple things like sensor-based hand washes, sensor-based lighting systems, all of these can come a long way in preventing wastage of energy. So they are ones to start off with. So that's how the footprint of the ICU is. The proposed pathway for sustainable green ICU is like this. It's almost on the same lines as what all of them have been talking about. Life cycle assessment, blah, blah. If you actually look into the literature, a few words, put them in a box, jumble them and pick your chit. These are the words that come up. It's something like this. So any article you come across, these are the same words that keep repeating again and again and again, but the concept is the same. Make sure that we are keeping a sustainable planet with us and not destroying the one that we are living on. There is something called as a green initiative and a stewardship. So this is how it is done. An audit is done, education to the stakeholders, multidisciplinary teams acting on it, cycle of change that is implemented, and local and global initiatives have to be formulated. So in this chaos, we also have to remember that our day-to-day ICU is full of confusion. So at some point, we will also have to attain some equilibrium. We will have to have a midpoint and a poise moment to make sure that we are aware of what we are dealing with, how much we are wasting, how much we are saving for the next generation. Only then it will be a balanced approach to humanity. Thank you. I thank all the panelists for having given their point of view. And for all the listeners, thank you for being there.
I was very green in my thoughts.
Please share your thoughts, Justin.
As a physician, like 20 years.
Yes.
20 years ago, the surgeons would come and say, all you physicians stand at the end of the bed and talk and talk and talk and write 120 LASIKs. Like at the end of the day, that's what.
Yes.
Less is more is not less is more. Like you can achieve less by thinking more and being mindful, like you rightly said. Thank you.
Agreed. Any thoughts from anybody? Yes. Yes, please.
Recyclable green sheets which back then which we used to use, sterilize and reuse them? That's the first question. And second question, we're all discomforted in the ICUs. We all work in ICUs day and night, especially in the nights when it is, the alarms are blaring and the visual monitors are just blaring around. Even the patients are discomforted for no sleep, and even we are discomforted. Is there any role where a central monitoring system can be made for all the monitors and in the nursing console, and the monitors can be muted automatically throughout the night, so the patient comfort is taken care as well as the noise pollution is taken care? So I want a thought from the panelists of these two questions.
Regarding first question, there are two ways of thinking. First is reusable sheets and switching over to, disposable sheets, switching over to green reusable sheets. So reusable sheets, disposable sheets have got a footprint, carbon
Definitely,
footprint.
yes, sir.
And reusable sheets also can have a footprint because when you
sterilization
autoclave
cost.
it,
Yeah.
there is an energy which is involved. You're using sterilization process. So we can sit and do a calculation based on the LCA and what is the carbon footprint output. If you feel, and it has been found that countries where renewable energy is used, this autoclaving process costs less carbon footprint. Where we use, where countries where fossil fuel is being used, there the carbon footprint of recycling, sterilization is more. So because we use more of fossil fuel, possibly for us using green sheet would be more carbon footprint wise
than using a single disposable one.
So we have to sit and think and calculate, only then we will come to a conclusion. Thank you.
Yes, sir.
For those reusable green sheets, lot of chemicals are used for washing.
True.
So again, those chemicals will also pollute the water. Okay, one. And now the cost of giving them for washing comes out more than the charges for the paper sheet. So that is how these sheets have come. And the second question about the thing, the noise, what the monitors make, I think that has to be seriously, worked on, so that the patients can sleep comfortably and next day morning on the rounds they don't irritate you. Okay. for that central monitor can be used where all the alarms can be seen at the central monitor and the patients can be there. But how? I mean, for that also then the headache comes from the nurses to the person who is sitting on the central monitor to monitor the patient. We need to have one person continuously sitting at the central monitor to watch. But at least there's this one. There are many equipments where if you want to minimize the audio alarm, that is not possible. You can set it, but once
in our monitors which we use, the Philips one, the lowest we can go up to is the volume of 4.
4.
Not below that. The monitor won't allow you to set below 4.
Below 4.
And
yes.
that 4 also is actually a
too
noise.
loud.
It
too
is
loud.
more than 80 decibels for sure.
Yes.
So
yes.
it is just the logistical issue of like the heads taking a call like this can be done or this cannot be done. The feasibility is one which I want to ask the.
There is a factory reset to all of these Philips monitor alarms. Even we have the same problem. So every time we call the biomedical engineer, he says, I'll have to see, I'll have to check. Nothing comes out of the whole discussion.
Exactly, sir.
So, but what you can do is with every patient change, when the new patient comes in, you can set it down to some level which is not too noisy. But the problem is once a patient moves out and the new one comes in, you have to do it again. Remind yourself to do it again. So that is where the challenge is. Consistency won't be there. But you can't blanketly reduce the limit to below a certain level.
No, there are monitoring systems like in Mindray, there's a night mode. Basically, in itself, it has an inbuilt night mode. When you switch on the night mode, it actually don't blare more than 2, the volume of 2. It will only, if you have attached CMS in the Mindray monitoring system, it actually blares there. In the CMS, it keeps a red alarm blaring out, telling that like there's an issue. I don't know, in Philips, it's the least which can be got is 4. I work with Rajendra sir in Hebal at times previously also. So the least which can be got is 4. Below 4, it cannot be done at all. As a factory reset, as a safety concern, probably they might have set it there. So, as a logistical thing, like at the supra levels of managing the ICU, can it be a feasibility? That's what is my question, sir. No, it's about the noise pollution as well as the patient comfort, both the parts.
Yeah. So if you are really worried about noise, nowadays the conference are there, silent conferences. So the people are sitting there and nobody hears anything, they are very silent. I think successfully conducted some ophthalmology conferences have been conducted. Yeah. In that way, only those person who is expected to hear his ear will be spoiled. I am worried. He only will be able to hear everything. Other people it won't be listening to that. So it may have to be something like that.
Okay.
On the same line with Dr. Rajendra, basically in Ramaya we use the sheets which have been used earlier. The students, they have to collect the reports and all, no? So they don't use fresh sheets. Otherwise, sometimes I do take the used books. There will be some papers left. The other thing is, recently we visited Andaman. They don't sell any half-liter bottle there. It's all 2 liters. I think all our conferences, probably if we, otherwise like we can get the 5 liter and certain cups, or in fact in Ramaya, the consultants sometimes they will get their own cups for the coffee, tea and all. Small things, it may sound little odd, but these are the things which we can do. Especially giving 500 ml bottle, I think the distillery is there here. So that is one of the
we
things
give
which
water,
we
I
can.
guess.
Ide. Madಬಹುದದು.
As we are running really late of the schedule, thank you everyone. I would request Dr. Chinnadurai sir to give away the token of appreciation to Dr. Radha. Dr. Radha ma'am. Dr. Ajit Kumar sir. Dr. Ajit Kumar sir. Dr. Rajendra Kumar. Dr. Vijay Reddy. Oh, is not there. Dr. Gopal Krishnan. Dr. Zahid. Dr. Varun Bhairappa. Dr. Venkateshwaran. Dr. Karthik Rao, sir. I request all the faculty and everyone present here to join for their group photo. At the outset, I would like to thank all our sponsors, Antara, Team Antara and Neon and Rivera Labs for sponsoring the event. Thank you. And thank you everyone, and also the audience who had joined and logged in online. We had a good online viewers as well, though it was an houseful event. Thank you everyone. Thank you for making time and attending the session and making it fruitful, successful. And thank you the AV team, and thank you to our marketing, Varsha and Rohit, for your efforts and putting up this show. Thanks. Yeah, I've told. Everyone please join. Everyone please join for the group photo, please.